so you don't feel the cold. And it's all for you. It's all for you. It's all for you. It's all for you. I did it all for you. It's all for you. It's all for you. It's all for you. Gonna let the sun shine in today. I'm trying to make this darkness go away. I'll paint with colors and I'll sing until my lungs give out. I'm gonna let the sun shine in today. And I will leave my windows open so that I can hear the sound of talking, the wind blowing in the trees. Oh, I will open up my eyes so I can see the light. Oh, and I'll try to spread my wings so I can fly. Oh, and the darkness starts to fade. Feels like things are gonna go my way. I'm gonna let the sun shine in the day. Gonna let the past be filled with smoke, and I will try to fix what has been broken, and take this weight off my shoulders, cause I know yesterday ain't coming back. I'm gonna let the past stay in the cold. I will listen to the ocean, let its unsaid words be spoken, and I'll let my mind be carried by the waves. Oh, I will open up my eyes so I can see the light. Oh, and I'll try to spread my wings so I can fly. Oh, and the darkness starts to fade. Feels like things are gonna go my way. I'm gonna let the sun shine in the day.
¿Se escucha bien? ¿Ahora sí? Vale. Bueno, buenos días a todos. Soy Javier de la Torre, el coordinador del Plan Andaluz frente al VIH, SIDA y otras ITS. Y es para mí un verdadero placer que estéis aquí a una hora tan temprano y hayáis hecho el esfuerzo un día de fiesta para estar con nosotros, para una sesión que para nosotros es muy especial porque vamos a presentar por primera vez los resultados de la cascada de VIH en Andalucía, datos de 2021 y datos por sus poblaciones. Esto es algo que muy pocos países lo han hecho y para nosotros es un verdadero placer y una satisfacción. Quiero agradecer a ONU-SIDA, a Fast Track Cities y también a IAPAC que nos haya permitido en este marco, en este congreso, donde ayer se firmó la Declaración de Sevilla, que estemos aquí. Y bueno, para todo esto, que es un proyecto que ha sido enorme, en gente donde hemos contado con mucha gente de la Consejería, de Andalucía, de múltiples ámbitos, contamos con dos personas que son las que nos van a hacer hoy la presentación. Por un lado, el doctor Nicolás Russo, que es responsable de epidemiología y asesor de la Consejería en Salud Pública, que hará una breve introducción y situará el marco de situación. Y por otro lado, con el doctor José Luis Jiménez, que trabaja en sistemas de información del SAS y que es quien va a presentar los datos. Luego, a última hora, si queréis, tendremos un rato para preguntas, cuestiones o dudas que tengáis. Inicialmente pensamos hacer la presentación en inglés, pero dado que estamos viendo que somos todos del mismo idioma y de la misma casa, yo creo que lo haremos en castellano, que va a ser más fácil y nos vamos a aclarar mejor. O sea, que cuando quieras, Nicola, adelante.
Pues muchísimas gracias, Javier, y bienvenidos y bienvenida a todas, ¿no?, aquí en Sevilla. No es casualidad que nos encontramos hoy en Sevilla, ¿no?, por el recorrido que también este ayuntamiento pues, ha hecho a lo largo de todos estos años para dar respuesta al VIH y de la mano también de la Junta de Andalucía, ¿no?, y de asistencia sanitaria. Sabemos todos que la comunidad pues, tiene un compromiso y adoptado realmente de acabar con la amenaza del VIH de acabar con el VIH como amenaza de salud pública para el 2030, ¿no? Un compromiso recogido también en la Asamblea General de las Naciones Unidas en 2015 y gracias a UNAIDS pues, se planteó en su momento. José Luis, ¿tú le puedes dar la primera diapositiva? Al darle a la segunda. Y como sabéis todos, pues a nivel internacional pues, se establecieron pues, la cascada del 90-90-90 y cero estigma relacionado con la respuesta al VIH a escala global. Y ahora pues, ya nos encontramos en una nueva fase, ¿no?, en una fase en la que necesitamos incluso dar un paso más, ¿no? Y por eso pues, también el título de esta charla que se había propuesto, pues ya miramos a los 95, ¿no? Eso porque sabemos que cada vez tenemos que mejorarnos y cada vez sabemos que estos objetivos pues, tienen que suponer solo una base de partida para todos nosotros, ¿no? Sabemos que lograr alcanzar este triple 90 al final quiere decir que solo el 73% de las personas que tengan VIH finalmente consigan suprimir la carga viral. Entonces, pues realmente pues, podéis imaginar que luego nos queda todavía casi un cuarto de estas personas a las que bien no llegamos o bien tenemos que desarrollar estrategias de prevención distintas o mejores, más específicas para poder subir este porcentaje de personas que realmente pues, suprimen su carga viral. A día de hoy, solo muy pocos países han logrado alcanzar el objetivo del triple 90. De hecho, son bastante dispares en términos de contexto socioeconómico, social, por lo que realmente los resultados y el estudio que se va a presentar aquí en esta sala realmente es un aspecto que es motivo de orgullo para todos nosotros. Porque además nos permitirá y nos permite también centrar el foco hacia aquellos grupos más vulnerables, porque lo que siempre hemos tenido bien claro era la necesidad de obtener estos datos no solo a nivel de magnitud global, sino también lograr escalar esta calidad de la información también a nivel desagregada. Sabemos que estamos en un momento que en los últimos años pues, estamos observando una disminución en el número de casos de VIH, especialmente en la parte de Europa occidental, en la que estamos España y, por supuesto, Andalucía, pero eso básicamente se debe a la reducción de los casos en hombres que mantienen sexo con otro hombre. Pero también somos conscientes de que tenemos que cada vez más tener intervenciones comunitarias transversales y que aunan esfuerzos de todas las partes, del ámbito de salud pública, del ámbito de asistencia sanitaria, las entidades sociales, la sociedad civil y, por supuesto, la ciudadanía y los mismos pacientes, que al final son los que llevan la carga de esta enfermedad y también muchas veces el estigma que conlleva la misma. Y además, cada vez nos enfrentaremos a problemas distintos y nuevos, como por ejemplo puede ser la resistencia al tratamiento de la PrEP, que necesitan que cada vez estemos pendientes con una vigilancia epidemiológica que nos permita también prevenir o bien identificar posibles intervenciones. Creo que Andalucía y Sevilla pues, son un buen ejemplo de cómo lograr esa integración y aunar esfuerzos hacia un objetivo común, que en este caso es el VIH. Y yo creo que, como he dicho al principio, pues no es casualidad que estemos hoy aquí. El objetivo del estudio que vamos a presentar, ¿no? Los que os vamos a presentar hoy en día, pues como hemos dicho, es la cascada del triple 90 en Andalucía en 2021. Sí resaltar que se trata de algo que nunca ha sido presentado y que a nivel nacional pues, los ejemplos son escasos y además con la calidad de datos que luego nos entrará más en detalle José Luis, realmente sorprendente. Y este proyecto, pues al final, no representa otra cosa que una oportunidad también para los agentes de salud pública, para todos los profesionales que trabajamos en el ámbito de salud pública, de poder dirigir las intervenciones de una forma apropiada en función de la realidad de la transmisión del virus en el territorio. Y por eso, pues, realmente pues, hemos resumido 3 objetivos que queríamos alcanzar con este estudio, que básicamente se trata de calcular la cascada del triple 90 para Andalucía e intentar desagregarlo por la población y los distintos subgrupos. También proponer una metodología adaptada a nuestro territorio y a nuestra fuente de información que nos permita que esta monitorización sea continua en el tiempo y, por supuesto, pues, centrarnos siempre en la utilidad que realmente tiene que tener este estudio, que no es otra cosa que identificar áreas de mejora y poner en marcha estrategias de prevención. Como podéis ver aquí, y algo que me gustaría destacar, es que realmente el gran éxito o sobre todo la importancia que tiene este estudio es sobre todo en la posibilidad que nos ha dado a todos los agentes que trabajamos en distintos ámbitos sanitarios, pero distintos, salud pública, farmacia, vigilancia epidemiológica, nos ha dado la oportunidad de alinearnos hacia un objetivo común, que realmente esto es la clave del éxito. El hecho, muchas veces disponemos de datos en distintas fuentes de información y la clave está en juntar esta información. Y realmente, pues, esta iniciativa al final también es lo que nos brinda un paraguas estupendo para poder aprovecharlo y realmente pues, realizar este tipo de estudios. Y por eso pues, realmente pues, la dificultad realmente ha consistido en tener que juntar la información de distintas bases de datos con distintas características y que también con la aplicación de determinados modelos en el que vamos a profundizar más tarde, que realmente han sido clave para el análisis estadístico. Básicamente, pues, destacar que se han utilizado datos procedentes de la base de datos poblacional de Andalucía, que es uno de los mayores éxitos de base de datos a nivel de salud que disponemos en el panorama nacional e incluso internacional, podría decir. Y luego, por otro lado, la base de datos del Sistema Epidemiológico de Andalucía, una información muy valiosa que sirve para analizar a nivel epidemiológico las tendencias de las distintas enfermedades y también, por supuesto, del VIH. Y también, como nexo de unión, tenemos la base de usuarios de los servicios sanitarios que nos permite también aunar y juntar la información de las distintas fuentes. Ya no me extiendo más, simplemente, como ya he dicho precedentemente, pues se trata de un logro importante que realmente tiene que consistir en un primer paso y que realmente somos conscientes de que haber logrado esta descripción que nos va a comentar, que nos comentaremos ahora, simplemente pues nos permite poder avanzar con más fuerza y con más evidencia sobre realmente la puesta en marcha de medidas e intervenciones de salud pública. Y sin más, pues le voy a ceder la palabra a José Luis, que realmente es el artífice y la mente de este análisis y que en detalle ya nos contará los resultados obtenidos.
Bueno, buenos días, muchas gracias por asistir, muchas gracias a los organizadores, gracias Javier por contar con nosotros. Bueno, empezamos un poquito con el método para estimar, sobre todo el primer 90%, que es lo que más quebraderos de cabeza nos dan. Utilizamos un software del CDC, que es el HIV Modeling Tool. Este software utiliza diferentes datos agregados de funciones, de diagnósticos incidentes de VIH, desagregados por el recuento de CD4 en el debut diagnóstico, los casos de SIDA, y todo lo junta y hace una especie de cálculo hacia atrás, teniendo en cuenta que el recuento de CD4 tiene que ver con el tiempo en el que la persona permanece sin tratamiento. Entonces, dibuja la curva epidémica de las infecciones incidentes, no de los diagnósticos que el sistema detecta. De esta forma se puede calcular, estimar el número de personas que viven con el VIH, incluidas aquellas que todavía el sistema no ha detectado, el infradiagnóstico. Es un modelo probabilístico, tiene un test de verosimilitud, hay que buscar el mejor número posible, la mejor cifra, pero al fin y al cabo tiene una parte artística, tú tienes que conocer un poco los datos, cómo han venido las diferentes bases, las épocas en las que la vigilancia y los criterios han ido cambiando. Entonces, ha sido una obra, pues, podemos someterlo a debate, pero ha sido muy laborioso. Comentar que para estimar tanto el segundo como el tercer indicador no hemos utilizado todos los datos que teníamos disponibles. Hemos sometido los registros que teníamos a reglas de validación para coger los diagnósticos VIH que seguro que sabemos que son VIH. ¿De acuerdo? Entonces hemos tenido una especie de pérdida de registros, aproximadamente menos del 9%. Igualmente, para calcular el tercer indicador, no hemos tenido acceso a todas las cargas virales de los pacientes que sabemos que están en tratamiento antirretroviral. Por tanto, debido a esta pérdida leve pero real de registros, hemos indicado el valor concreto, el valor puntual del indicador y intervalos de confianza. Bien. En total obtuvimos unos 50.798 registros de personas con VIH diagnosticadas entre 1984 y 2021. Las bases, como ya ha dicho Nicola, son la base poblacional de salud y el sistema de vigilancia epidemiológico de Andalucía. Yo he de decir aquí que estas dos bases de Andalucía tienen oro. Tienen oro no solamente en este tema, en el VIH, sino para otras enfermedades. Es realmente valioso lo que tenemos. Se recogieron un total de 11.713 defunciones de personas diagnosticadas con VIH, un total de 16.277 casos de SIDA concurrente en el debut diagnóstico y actualmente, a finales de 2021, habría usuarios en activo con diagnóstico conocido de VIH, un total de 22.916 personas. De acuerdo. Esta sería la pirámide de población, la pirámide de prevalencias de personas con VIH. En Andalucía tendríamos en total una prevalencia de 0,28% para el VIH. En hombres es mayor, 0,46%, y en mujeres 16%. Vemos cómo las cortes de personas que tenían entre 51 y 60 años son las más afectadas, con prevalencias incluso de 1,6%. Bien, actualmente las personas que viven con VIH en Andalucía, el 78% son hombres, el 22% son mujeres, el 46% son mayores de 50 años. Aquí hay que hablar de las cronicidades, las complicaciones con el tratamiento. El 33% son o fueron usuarios de drogas inyectadas, el 44% son hombres que tienen sexo con hombres, el 21% son heterosexuales, hay un pequeño porcentaje de otras vías de transmisión más minoritarias, como fueron las transfusionales o la vertical de madre a hijo. El 32% de las personas con VIH en Andalucía viven en una zona de transformación social y el 32% igualmente fueron diagnosticadas en estadios tardíos. El 86% son de nacionalidad española y un 13% son ciudadanos extranjeros, de los cuales el 36% son de Latinoamérica o Caribe, fundamentalmente de países hispanohablantes. El 30% de estos extranjeros son europeos, fundamentalmente Europa Occidental. El 28% son africanos, fundamentalmente subsaharianos. Y bueno, un 6% de otros orígenes. Bien, el primer 90%. Esta es la curva que nos devolvió el software del CEC. Actualmente Andalucía cumpliría el primer objetivo de ONU-SIDA, datado para el 2020. Nosotros lo cumplimos en 2021. En 2020 no lo hubiéramos cumplido. El intervalo de confianza para 2021 es amplio y incluye también el 10% de infradiagnóstico, pero creemos que lo estamos cumpliendo. Tenemos un 9,62% de personas con VIH no diagnosticadas y vamos camino del 5%. Sin embargo, creo que hay que interpretar con mucho cuidado este indicador porque hay algo que ha ocurrido en estos 2 últimos años, que es la pandemia por COVID-19. En la curva punteada de color rojo a la derecha vemos la tasa por 100.000 personas año de nuevos casos diagnosticados de VIH en Andalucía y vemos la bajada significativa que hay en 2020 y 2021. ¿Por qué puede haberse producido? En primer lugar, por la sobrecarga del sistema sanitario y de los sistemas de vigilancia. Esa es la primera razón. Otra puede ser también que, como vemos en las barras azules, ha habido desde 2019 una implementación progresiva de los usuarios en PrEP. Eso también puede haber reducido el número de nuevas infecciones. Y también puede ser que la política de restricción de movimiento de la ciudadanía para reducir la infección por COVID haya producido también una reducción de contactos sexuales, incluidos los contactos sexuales infectivos. Puede ser. Sin embargo, fijándonos en el gráfico de la izquierda, vemos que el gráfico de la izquierda representa en forma porcentual y en función del rango del linfocito CD4 al diagnóstico, los diagnósticos incidentes desde 2014 a 2021. Vemos cómo el patrón más o menos ha sido el mismo. No creemos que se haya modificado sustancialmente el patrón de presentación de los nuevos diagnósticos. Entonces, creemos que no ha habido una reducción significativa o muy llamativa de la incidencia de nuevas infecciones, sino que quizá estamos hablando de un retraso en la notificación de diagnósticos. Entonces, hay que ponernos las pilas. Sin embargo, el indicador habla de que la tendencia decreciente en los últimos años del infradiagnóstico. El software también nos permite conocer el número absoluto de usuarios no diagnosticados. Tendríamos 2.557 personas no diagnosticadas en Andalucía, de las cuales tendríamos un 5% en primoinfección, un 39% con más de 500 CD4. Los 500 CD4 bajan a menos de 500 a partir de los 2-3 años, son infecciones relativamente recientes. Y luego tendríamos pues, prácticamente más del 30%, las porciones amarilla y naranja, con diagnóstico con presentación tardía. Y están hoy mismo sin diagnosticar. Entonces, sí, Andalucía cumple el primer objetivo de ONU-SIDA para 2020, el 90% de diagnosticados. Bien, pasamos a hablar del segundo 90%, los usuarios linkados al sistema y que están en terapia antirretroviral. Andalucía cumple, tenemos un 9,7% de usuarios en tratamiento antirretroviral. Desagregado por sus poblaciones, vemos cómo los hombres cumplen el objetivo y las mujeres están cerca, pero no. Y esto tenemos que vigilar por qué está ocurriendo. Estamos hablando también de finales de 2021, hay una contracción de la actividad del sistema sanitario por la pandemia. Puede haber varias razones, pero las mujeres no llegan al 90% a finales de 2021. Los mayores de 50 años y menores de 50 años igualmente cumplen el objetivo del 90% de tratamiento. Bien, las personas que viven en una zona de transformación social están rozando el objetivo, pero no llegan a una cobertura del 90%. Sin embargo, los que no viven en esas zonas sí lo cumplen. Igualmente, las personas que tuvieron un diagnóstico tardío sí cumplen y además con creces el objetivo de ONU-SIDA. Esto se debe a que el sistema se desborda con ellos, ¿no? Intenta darle todo y lo más rápido posible. Sin embargo, los diagnósticos no tardíos tiene un 89,4% de cobertura. Quizá habría que recortar los tiempos entre diagnóstico e inicio de la terapia antirretroviral. Bien, los usuarios de nacionalidad española cumplen el objetivo, los extranjeros también, pero si nos vamos al origen concreto, vemos que, y voy a destacar, el caso de los usuarios de origen africano no cumplen el objetivo de cobertura antirretroviral. Esto se debe a un problema, puede ser de adherencia, pero sobre todo de acceso al sistema. Los usuarios del resto de Europa tampoco lo cumplirían, sin embargo, creemos que este dato está sesgado porque creemos que estos usuarios mantienen un proveedor de servicios diferente al sistema sanitario andaluz a la hora de obtener la medicación antirretroviral. Entonces, ese 88% está sesgado por una falta de registros que nosotros tenemos, ¿de acuerdo? Sin embargo, el dato de usuarios africanos creemos que es muy posible que sea real. Perdón. De acuerdo. Pasamos al tercer 90%. Conseguir la indetectabilidad en las personas que tienen terapia antirretroviral. Y, efectivamente, Andalucía vuelve a cumplir el objetivo con un 91,9% de usuarios linkados al sistema en tratamiento antirretroviral y con carga viral indetectable, definida esta como menos de 50 copias partido mililitro de ARN. Tanto hombres como mujeres cumplen el objetivo. Los mayores de 50 años cumplen el objetivo con creces, una idea para felicitarnos. Y los menores de 50 años igualmente también. De acuerdo. Los usuarios de origen español, el 92% son indetectables. Los extranjeros no llegan a ser indetectables como colectivo, luego desagregamos por origen. Y tanto las personas que viven en zonas de transformación social como las que no, igualmente son indetectables la mayoría, más del 90%. Vale, pasamos al origen. Los usuarios extranjeros de origen europeo cumplen el objetivo con creces. Los usuarios africanos vuelven a suspender, no consiguen el objetivo para 2020. Y los usuarios latinoamericanos y caribeños tampoco. Por vía de transmisión, comentar que los hombres que tienen sexo con hombres cumplen el objetivo, la población heterosexual también, los usuarios de drogas inyectadas. Y, bueno, hay un pequeño número de personas con otras vías de transmisión más minoritarias que están ahí rozando el objetivo. Comentar que alrededor del 40% de registros que tenemos diagnósticos no conocemos la vía de transmisión. Es un colectivo importante que debemos dilucidar. Y en función del estadio clínico al diagnóstico, vemos que las personas que no tuvieron un diagnóstico tardío tienen una carga viral indetectable por encima del 90%. Sin embargo, los que tuvieron un diagnóstico tardío les cuesta más llegar a este objetivo debido a la situación clínica más perjudicada que tienen al inicio de la terapia antirretroviral. Como resumen, las poblaciones clave a la hora de priorizar deben ser, en primer lugar, las mujeres en el acceso y en la adherencia al tratamiento antirretroviral. Las personas que no tuvieron un diagnóstico tardío deben tener acceso a la terapia antirretroviral con tiempos menores desde el diagnóstico. Habría que mejorar también tanto el linkaje al sistema como la adherencia al tratamiento antirretroviral para los usuarios de drogas inyectadas, igualmente para los usuarios de origen africano. En cuanto al tercer indicador, en color rojo, deberíamos tener un tratamiento antirretroviral óptimo y una buena adherencia en usuarios latinoamericanos, caribeños y africanos, e igualmente para los usuarios que tuvieron un diagnóstico tardío en el debut, incluyendo la monitorización de sus complicaciones. Igualmente, hay que seguir apostando por el screening periódico del VIH y la implementación de la PrEP para aquellos colectivos que tienen una exposición elevada al virus del VIH. E igualmente para todos, educación sexual, promoción de la salud sexual, para todos y siempre. Y bueno, esto es todo. Gracias por vuestra atención y estamos aquí para vuestras preguntas, las que queráis.
Muy bien,
verdad es que nos hemos quedado encantados. Yo creo que son unos resultados fenomenales. Yo creo que es para, como ha comentado Nicola, para sentirnos orgullosos. También remarcar que hay una serie de claves que nos dan estos resultados, que son las zonas, los sitios, los puntos donde tenemos que trabajar, que incidir más. Esto nos pone deberes a la hora de trabajar con los presentadores tardíos, a la hora de trabajar con las zonas en más vulnerabilidad, a la hora de trabajar con los africanos, a la hora de trabajar con las mujeres. Yo creo que estos son unos resultados que nos van a ayudar mucho y además, como ha comentado muy bien José Luis, estos son resultados que vamos a poder repetir cada año con la misma metodología una vez que ya tenemos hecho la forma y el diseño adecuado. Entonces, esto creo que va a ser de gran utilidad. No sé si queréis hacer alguna pregunta, algún comentario. Adelante.
Se escucha, ¿no? Valentín Márquez, de Médicos del Mundo. Me ha encantado la presentación. Me ha llamado la atención algo que nosotros ya estamos llevando a cabo, ¿no? Es el tema de los barrios desfavorecidos, ¿no? De hecho, nosotros, por ejemplo, anualmente la semana de la prueba la solemos hacer en barrios desfavorecidos. Y es que en estos barrios coincide también la población migrante, que es otra que hemos señalado con dificultades de acceso a la detección precoz, porque en estos barrios, evidentemente, es donde es más barato vivir y donde se ha detectado la concentración de población española con escasos recursos, pero también mucha población migrante que en muchos casos nosotros detectamos que tienen poca información sobre VIH. No tanto la población latinoamericana cuanto la población del África subsahariana. Tienen bastante poca información y cierto rechazo cultural al tema de hacerse pruebas, sobre todo cuando son de sangre, ¿no? Pero eso, destacar la importancia del trabajo en estas poblaciones y bueno, dar la enhorabuena a la Consejería por este trabajo. Gracias.
Bueno, yo creo que efectivamente, como comentas, estos son colectivos, estas son situaciones donde a veces la sanidad pública llega hasta donde llega y a ellos necesitamos a vosotros, a todo el tercer sector, sin los cuales es imposible que lleguemos a todas estas personas. Sí ayuda esto a saber que aquí tenemos un gap, aquí tenemos un agujero, tenemos una zona que tenemos que mejorar y probablemente tengamos que desarrollar estrategias para llegar a esta zona, a estos colectivos, de la mano, conjunto, para mejorar estos resultados. Muchas gracias por tu comentario. Eduardo.
De Sevilla, enhorabuena por el trabajo. Yo te haría dos preguntas. Una, por un lado, quizás no es el foro, ¿no?, sobre la validación metodológica y que hemos hecho con los missing, que sabemos que hay muchos, ¿no? El problema de los falsos positivos en la BPS, etcétera. Pero realmente lo que creo que aquí interesa es la aplicabilidad de este modelo en las ciudades, ¿no?, que es el objeto del Fast Track, ¿no?, y especialmente en la ciudad de Sevilla, ¿no?, que, como sabéis, hemos hecho un trabajo reciente donde pues, coincide en que no mejora el diagnóstico precoz ni disminuye la incidencia de casos y, además, coincide también en el diagnóstico de qué poblaciones son las más desatendidas ahora mismo, ¿no? Entonces, no sé si se puede aplicar el modelo a un entorno como la ciudad de Sevilla.
Bueno, sobre la validación, las reglas de validación, lo que hicimos fue, como tenemos diferentes fuentes de origen de los registros, el CMBD, atención primaria, consultas externas, urgencias de AP, urgencias de hospital, intentamos que el diagnóstico que pasa a formar parte de un indicador tiene que estar en varias fuentes. Si no está en varias fuentes recogida la información de un diagnóstico de un paciente, no entra. Perdimos un 10% aproximadamente de registro, es decir, que es robusto el indicador. Y después el software se puede aplicar perfectamente. En ciudades grandes se puede aplicar, yo creo que perfectamente. La historia es tener registros de CD4 suficiente, porque es lo que te va a dar la clave para situar al paciente en cuándo se infectó y no cuándo se diagnosticó.
Claro, eso falta en muchos casos, porque hay un problema de disponibilidad de esa información en las bases de datos. No lo hemos comprobado nosotros cuando hemos intentado ir a buscar, ¿no? De todas maneras, lo que sí hubiera sido interesante es introducir la variable urbano-rural, ¿no? Que no hubiera sido difícil, probablemente, a nivel de Andalucía, ver si hay diferencias sustanciales, ¿no? De todas maneras, bueno, me parece que aporta una información y un modelo de absoluto interés para ver de cara al futuro y, bueno, realmente una llamada de atención de que, bueno, de que los esfuerzos que estamos haciendo están teniendo realmente poco efecto hasta ahora, ¿no? En cuanto a la incidencia, en cuanto al diagnóstico tardío.
Gracias.
En la línea de lo que tú dices, Eduardo, efectivamente, una de las cosas que sacas también de lectura, más allá de los datos, de que nos guste y del análisis sobre el VIH, es qué importante es la calidad de los datos y cómo tenemos que mejorar los sistemas de información. Hablándolo con José Luis, hablándolo con Nicola, necesitamos en general, y por eso esto es tan difícil de tener la cascada, porque la inmensa mayoría de los sitios, otras comunidades autónomas que nos lo han comentado, no tienen registro, no tienen datos de todo lo que está contando José Luis, ¿no? Entonces, en los deberes que nos ponemos está el seguir mejorando la información, el seguir mejorando los datos. Andalucía tiene algunas fortalezas, como es que tenga un sistema único de base de datos para recoger la historia clínica, tiene un sistema de epidemiología muy potente y tiene una base de datos poblacional que es de las más avanzadas, si no la más avanzada de España. Pero es insuficiente. Aún así, la calidad de los datos, ha contado muy bien José Luis, como hay algunos sesgos y algunas veces hemos tenido que dar intervalos de confianza porque no nos salían los resultados ajustados. Entonces, esto es uno de los deberes que nos llevamos, una segunda enseñanza que nos llevamos de este trabajo. No sé si tú quieres comentar algo de todo esto, Nicolás.
Sí, realmente, pues en este sentido, yo realmente, además de que es una oportunidad única para poder detectar realmente cuáles son las áreas de mejora pues, en nuestro trabajo, también, por supuesto, es una oportunidad para nosotros para afianzar los circuitos de transmisión de la información, porque también pues, este estudio pues, también lo que nos viene a decir que necesitamos mejorar la calidad de los CT4, necesitamos mejorar pues, la accesibilidad para determinados colectivos y también en determinadas áreas, por lo que realmente, como os decía antes, la importancia de este estudio es que realmente nos da evidencia sobre cuáles son los argumentos para sustentar nuestras medidas de intervención en el territorio, que yo creo que es lo más importante y lo que realmente nos tenemos que llevar. Bueno, muchos de vosotros lo sabéis, ya en Andalucía disponemos de un protocolo de estudios de contacto ante VIH e ITS. Hemos llegado incluso tarde, pero no obstante somos la segunda comunidad a nivel de España que tenemos un protocolo de este calibre después de Cataluña. Y la experiencia también de una de las compañeras que también nos acompaña esta mañana en Distrito Jerez, pues también nos da la idea de la importancia de un abordaje integral del VIH y dentro del entorno también de otras infecciones de transmisión sexual que, como sabemos, pues están en una situación dramática y que también requieren no solo centrar los esfuerzos en el VIH, sino también contra otras ITS. Y yo creo que este es el camino que tenemos que hacer y que tenemos que fortalecer, disponer de protocolo, poner a trabajar los profesionales en ámbitos concretos para la prevención también de infecciones, pues, de coinfecciones y también del VIH, pero también de otras infecciones de transmisión sexual, y fortalecer estos canales de comunicación y que el dato esté accesible, porque muchas veces el dato se encuentra disponible, pero no logramos llegar a captarlo en los grandes sistemas de información, o bien el mismo profesional que es el encargado de recoger esta información no accede a este dato, por lo que realmente luego el sistema de información no llega a tener esa calidad deseable. Pero ese estudio realmente pues, nos da la idea de la potencia y realmente del alto grado de capacitación que disponemos aquí en Andalucía para producir y alcanzar este tipo de resultados. Y la experiencia también, lo vuelvo a repetir, de la ciudad de Sevilla también ha sido clave para realmente encauzar desde hace varios años la posibilidad de estar aquí, porque realmente ha sido como un motor que ha aunado también esfuerzo alrededor de un objetivo en el que hemos sido todos encantados, hemos estado todos encantados de participar.
Fernando, adelante.
Buenos días. Yo, en primer lugar, dar las gracias por el magnífico trabajo que habéis hecho, el esfuerzo que ha supuesto Y bueno, ahora venía pensando que iniciamos próximamente el segundo plan y esto realmente nos va a dar unos datos científicos que nos va a aportar para un buen planteamiento de los objetivos y las líneas de trabajo que tenemos que llevar. Yo creo que posiblemente todos los que estamos aquí del comité están pensando lo mismo, ¿no? Las líneas y el trabajo lo vamos a enfocar directamente a esta población, a esta más vulnerable, estos diagnósticos tardíos que estamos haciendo y simplemente volver a reiterar las gracias por el esfuerzo, el magnífico trabajo que habéis hecho y nos estáis marcando las líneas, unas líneas muy importantes de lo que va a ser el próximo plan de Fast Track Sevilla. Gracias.
Gracias, Fernando.
Gracias.
Buenos días. Yo soy Juan Luis del Can de la Fundación Atenea. Nosotros pertenecemos al comité Fast Track de aquí de Sevilla y me uno a las felicitaciones por el trabajo presentado. Y bueno, yo quería hacer una propuesta al hilo también de lo que decía mi compañero Valentín, y es en el contacto que tenemos las entidades del tercer sector, que intervenimos con personas que presentan enfermedades infecciosas como VIH o hepatitis. En esa recogida de datos, a veces nosotros tenemos cierta complejidad para aportar los datos a la consejería, al área de salud. Entonces, a ver de qué forma pudiéramos contar con alguna herramienta útil, práctica, ágil y que contara un poco con ese traspaso de datos, que nosotros a veces llegamos a población donde la administración a veces le cuestan, estos barrios vulnerables y de zonas de transformación social, a ver si pudiéramos también seguir colaborando en ese trabajo de una manera más dinámica, como digo, a modo de sugerencia. Muchas gracias.
Muchas gracias, Juan Luis. En el nuevo plan que ha comentado Fernando, una de las cosas que queremos es revisar todos los circuitos y desde que salta el primer diagnóstico, cómo es ese circuito para optimizarlo, no perder tiempos y cuanto antes, desde el diagnóstico, se vincule y esa persona esté tratada y esté seguida y, a su vez, reforzar las medidas de apoyo, contando, como no puede ser de otra manera, con vosotros, con todo el tercer sector, para que estas personas estén bien seguidas y se cuente con soporte suficiente para que estén bien vinculados y tratados. Gracias, Juan Luis.
Hola, Diego García de Adara. Felicidades, José Luis, por el trabajo que has hecho. Magnífico, y felicidades a todo el equipo de la Consejería por tener este trabajo que nos sitúa muy bien donde estamos. Una pregunta. ¿Estáis pensando para los años venideros disgregar en población cis y trans? Porque quizás sería muy necesario el poder tener una idea clara de qué está pasando en esa población y, unido a esto, lo que vemos en nuestra realidad es que muchas personas que tienen peor acceso o que son personas también que están en situación de prostitución y encima con falta de papeles. Entonces, quizá ahondar un poquito más dentro de situación de migrante o no migrante, ver en qué situación está, si de prostitución o no, además de trans o cis, podría afinar muchísimo más la imagen de la situación real de esas personas. Gracias.
Podemos afinar todo aquello que esté recogido en las bases de datos. O sea, me explico. Nosotros no inventamos, ahora lo va a explicar José Luis, pero nosotros no inventamos nada. Todo aquello que esté idealmente en dos bases recogidos son datos robustos, entonces podemos explotarlos. Podemos dar los datos por Sevilla porque tenemos los datos de Sevilla. Podríamos dar los datos por provincias de la cascada porque tenemos los datos por provincia. El tema concreto de Cincitran, José Luis.
Digo la verdad, he tenido durante todo este proceso de trabajar con los datos, en mi conciencia, ¿dónde está la población trans aquí identificada? No tenemos hombre o mujer,
no está recogido.
O desconocido, pero el marcaje desconocido creo que es por una falta de registro, no porque designa a la población trans. Podríamos repescarlos por las citas que tengan con endocrino, por ejemplo, o con ciertas intervenciones de reasignación y por ahí marcarlos. Podríamos hacerlo así. Yo creo que a nivel de la base de datos poblacional se podría en el caso de trans, pero en el caso de la prostitución va a ser muy difícil. La estimación de cómo está esta población debería ser directamente con estudios directos sobre esta población, empíricos.
Quizá una de las conclusiones que podemos traer, que a lo mejor pues sí hacer estudios más específicos. En este caso sí, podríamos intentar a lo mejor hacer un estudio más dirigido a este tipo de grupo, porque pensar que los datos que muchas veces recogemos no tiene esta pluralidad o esta... Es decir, y para nosotros realmente el nivel de desagregación que hemos logrado con este estudio es que inimaginable hace muchos años, pero nosotros entendemos también que para vosotros pues no es suficiente y que también pues necesitamos dar un paso más, pero también podemos pensar también en estrategias distintas que no sea a lo mejor de grandes números, sino a través también de experiencias concretas a nivel local que también se puedan digamos, aplicar también al resto del territorio.
Buenos días. Bueno, daros la enhorabuena de nuevo y bueno, pues sentirnos orgullosos, orgullosas y orgullosos de que Andalucía y Sevilla esté otra vez liderando algo que debería estar haciendo todo el Estado español y sus comunidades autónomas. Siguiendo un poco lo que decía Diego, que era la discusión que teníamos, entendemos que en el cómputo global de datos a más de tantos años es muy difícil la segregación cis-trans, pero sí igual lo que un poco planteamos es lo que decías, Nicola, ¿no? El poder empezar a hacer como un poco más de investigación específica, especialmente porque hablamos siempre de departamentos estanco y al final es un poco lo que estaba definiendo Diego. Normalmente los perfiles actuales que encontramos es una mujer, migrante, trans e incluso consumidora de drogas o de kensex en algunos momentos. Entonces, a veces se nos queda un poco estos marcos tan grandes, muy difíciles, sobre todo para luego buscar esos casos y esas intervenciones. En la comunidad nos parece muy interesante también que se haga ese efecto de disgregar entre usuario UDI, de drogas inyectadas, de lo que es el espectro clásico que pensamos del usuario o usuaria de kensex, que creemos que es además una de las cosas que tenemos que incidir cada vez más. Y es un perfil radicalmente distinto en cuanto a zona geográfica de vivencia, prácticas, intervención, etcétera. Entonces sería interesante tanto hacer ese análisis para personas trans como para usuarios, usuarias de kensex. Y luego teníamos también una curiosidad o un planteamiento precisamente en el infradiagnóstico y ese grupo grande de personas no diagnosticadas que habéis inferido de los datos. ¿Qué zonas se pueden interpretar más o menos de la comunidad autónoma en las que más encontremos ese infradiagnóstico? Precisamente para acompañaros, ¿no? En programas específicos. Estamos aquí, las entidades que más podemos realizar ese camino precisamente que decías, Javier, de acompañar al sistema en buscar esos perfiles difíciles en distintas zonas. Entonces sería muy interesante dentro del mapa epidemiológico que habéis hecho ver, pues mira, están en esta provincia o podemos, aunque sea a grosso modo, ¿no? Para empezar en ese nuevo plan y en los próximos pasos a buscar programas específicos. Gracias.
Muchas gracias, Jorge. No sé yo, José Luis, si el dato de las personas del primer 90 lo tenemos o lo podemos calcular por provincias.
Se podría intentar, lo que pasa es que los intervalos de confianza van a empezar a ampliarse. Podría, a lo mejor, viendo de dónde vienen estas personas con diagnósticos tardíos, ¿no? Podríamos aproximar si vienen de zonas rurales, si vienen de zonas metropolitanas o ya estamos hablando de zonas...
Ya esos datos pueden ser relevantes.
Podríamos intentarlo, sí.
Muy bien.
Y sobre el tema que va a ser... No sé, yo creo que los sistemas de vigilancia no dan cuenta hasta... Normalmente o es HSH o es usuario de droga y si la vía de transmisión... Siempre se coge la vía de transmisión de más riesgo, entonces en este caso caería por la vía de los UDI. Es complicado.
Isabel.
Buenos días, felicitaros por el trabajo, por el manejo de los datos, que yo sé a día también porque trabajo con muchísimos datos, yo soy epidemióloga. Me llamo Isabel Román y trabajo en el distrito Jerez Costa Noroeste, donde ha mencionado Nicola que estamos realizando los estudios de contacto desde hace casi 2 años, unos resultados estupendísimos, y que en un principio comenzamos con las ITS, pero desde enero de este año estamos empezando con VIH. ¿Vale? Entonces, comentaros que realizar los estudios de contacto aumentarían el diagnóstico precoz de todos aquellos no diagnosticados. Nosotros, hasta el momento, los datos que manejamos son únicamente desde enero de 2022, pero deciros que en el primer trimestre se diagnosticaron 14 casos, cuando en los 5 años previos no se diagnosticaron más de 3-5 casos. Entonces, hemos llegado a triplicar y más los casos que se diagnosticaban. Entonces, hay que hacer estudios de contacto, pero los estudios de contacto los tienen que hacer personas que estén bien formadas y bien capacitadas en ellos, sobre todo en estos temas tan sensibles, ¿vale? Donde necesitan no solo tener un conocimiento clínico, sino tener empatía, un buen abordaje y, sobre todo, conocimientos en cuestiones ético-legales que muchas veces donde se nos presenta la mayor dificultad es a ese nivel. Entonces, pues yo creo que la vía y los servicios de salud pública lo que podríamos aportar es la rigurosidad de realizar los estudios de contacto, que en el caso de VIH son complicadísimos y que nos llevan incluso a retroceder a toda la vida sexual de una persona. Por poner un ejemplo, de esos 14 diagnósticos, de una única persona se diagnosticaron 10. ¿Vale? Entonces, es importantísimo realizar esos estudios de contacto. Hasta ahora una herramienta que no se utiliza apenas en toda España, que en Andalucía la vamos a implementar, pero que en todo el mundo no se utiliza. Y no solo eso, sino que hay que tener una rigurosidad de los datos y casar caso índice con todos sus casos secundarios para que después podamos obtener conclusiones y encontrar áreas de mejora, como estamos haciendo nosotros día a día allí. Muchas gracias.
Gracias, Isabel. No sé si quieres hacer algún comentario.
Sí, no, felicitar pues realmente pues una vez más el trabajo que están haciendo en Jerez y que realmente pues ha sido pues nuestro motor de partida para poder tener la fuerza de disponer de un protocolo para toda Andalucía, porque los resultados que se están teniendo pues son envidiables. Y también nos ayuda cada vez más a entender la necesidad de compartir la información, la necesidad de poder acceder a cualquier caso de gonocosia, de clamidia, de herpes genital, porque de un estudio de contacto de cualquier tipo de ITS muchas veces las coinfecciones, el porcentaje de coinfecciones es tan alto que realmente merece la pena, y en esta fase en la que estamos de situación epidemiológica de infecciones de transmisión sexual es una buena práctica de las que estamos orgullosos y de las que sabemos que Jerez nos ha puesto el listón también muy alto, y estamos contentos para lograr estos resultados también en otros distritos de forma lo más rápido posible.
Se me olvidó comentar, y ya que estamos aquí todos, lanzar la mayor problemática que nosotros tenemos, que tenemos una gran cantidad de contactos anónimos y localizables debido pues, a las nuevas búsquedas de parejas sexuales, apps, web, sitios de cruising, ¿vale? Sauna. Entonces, yo lanzo al tercer sector, por favor, esa ayuda de combinar los estudios de contactos que estamos haciendo nosotros de manera clásica a cómo podríamos llegar a toda esa gente, ¿vale? Nosotros hasta el momento lo único que hacemos es entregar tarjetas de notificación que entregan a sus parejas si las volviesen a ver, pero para nosotros es un gran reto y no sabemos cómo abarcarlo, ¿vale? Entonces, lanzo aquí para que, como hay muchas cabezas pensantes, pues podamos hacerlo bien. Yo creo que el futuro sería realizar los estudios de contacto y podríamos llegar a muchísima gente, ¿vale? Venga, gracias.
Gracias, Isabel.
Gracias, Isabel. Pues la verdad es que este es un debate apasionante. Todo el tema de la información, todo el tema de los estudios de contacto, los datos que ha contado Isabel son fenomenales. Probablemente si fuéramos capaces con cada nuevo diagnóstico, fijaros que en Andalucía cada año estamos alrededor de 500 nuevos diagnósticos. Si hiciéramos estudios de contacto reglados y sostenidos de esos 500 casos, probablemente nos saldrían más, iríamos disminuyendo más esta fracción no diagnosticada, y tenemos un reto, y igualmente lo que comentó Isabel, comentar con el tercer sector y establecer actuaciones conjuntas para que no se nos escape ninguna de estas personas que están en estos entornos, sería un reto. Agradeceros a todos vuestra asistencia, agradecer a la Consejería de Salud que haya hecho posible que hagamos esto, a la gente que trabaja en sistemas de información, sin los cuales esto hubiera sido imposible, a la gente de farmacia, a la gente que ha estado también en los hospitales, a la Dirección General de Asistencia Sanitaria y a Epidemiología, que son los verdaderos responsables de este estudio, y agradeceros a todos vuestra asistencia en una mañana de fiesta tan temprano. Muchas gracias.
Until my arms give out, I'm gonna let the sun shine in today, and I will leave my windows open so that I can hear sound of people talking and the wind blowing in the trees. Oh, I will open up my eyes so I can see the light. Oh, and I'll try to spread my wings so I can fly. Oh, and the darkness starts to fade. Feels like things are gonna go my way. I'm gonna let the sun shine in the day. I'm gonna let the past be filled with smoke. And I will try to fix what has been broken. And take this weight off my shoulders, 'cause I know yesterday ain't coming back. I'm gonna let the past stay in the cold. I will listen to the ocean, let its unsaid words be spoken. And I'll let my mind be carried by the waves. Oh, I will open up my eyes so I can see the light. Oh, and I'll try to spread my wings. this every day, and I'm still so amazed by you. So hold me tight through the night. It's just us two, me and you. Oh, oh, I can't believe you love me. Oh, oh, I just feel so lucky. Oh, oh, still can't believe you love me. I hope it never ends. Let's be more than friends. Yeah. You know I'm here to stay every single day. Yeah. So hold me tight through the night. It's just us two, me and you. Oh, oh, I can't believe you love me. Oh, oh, I just feel so lucky. Oh, oh, still can't believe you love me. Falling into your arms, dancing up in the stars. Oh, where I'd rather be.
Sit or exit? Thanks. Hi, Zoe. How are you?
Oh, I just feel so lucky. Oh, still can't believe you love me. Oh, I can't believe you love me. Oh, I just feel so lucky. Oh, still can't believe you love me.
On? Yes, very on. So, good morning, everyone, or good afternoon, or good night for the ones who are watching online. I'm aware we're operating in different time zones. Thank you for making it to this satellite session on achieving zero, developing indicators for measuring stigma. Just before we start, also my name is Tanja Ditfeld. I'm the Regional Director for Europe for the Fast Track Cities Institute, and this is a satellite session that has been done in collaboration with all the other regional directors from the Fast Track Cities Institute. And I'm just here to give opening remarks before giving the word to people who know much more about stigma and indicators. But why are we talking about stigma? That is pretty clear. This session is not about establishing why we're talking about HIV-related stigma. I think preaching to the converted here, we know that HIV-related stigma in its different forms, whether it's anticipated, experienced, internalized, contributes to poor health outcomes. It deteriorates uptake, access, and availability of HIV testing, prevention, and treatment. So we already know the why of HIV-related stigma, like why are we talking about it? It's therefore also no surprise why we have so many different political commitments, declarations to actually combat HIV-related stigma, to end the HIV epidemic. The political commitments are clear, both at city, regional, and international level. But I think beyond the political commitments, we also have a moral or even human commitment, particularly if we look at what studies still show about what people living with HIV feel about living with HIV. For example, there was a study done in the US recently that showed that 1 out of 4 people who are living with HIV are feeling disgusted by themselves. That is completely unacceptable. So, again, we know a lot about what stigma does, HIV-related stigma does, in terms of hampering our progress towards ending the HIV epidemic. What we know very little about is how to actually measure our progress when it comes to HIV-related stigma. There is a lack of validated and standardized tools to measure stigma. There are many initiatives happening in different fast-track cities. There are a few cross-regional initiatives happening, but there is still a scarcity of standardized and validated indicators. And why do we need indicators? Well, again, we want to actually be able to, in a unified manner, measure our progress. We want to be able to compare, maybe even also compete on progress. We want to be able to see if our interventions work, and we want to see if our interventions do not work. So, today's session is twofold. We are first looking at what are some of the tools, indicators, surveys that already exist. This is the first segment of today's satellite session. And then we're trying something a little bit new for at least fast-track cities conferences, which is moderated roundtable discussions to see if we can actually come up with indicators and data collection questions. And just to do some expectation management, it's not that I or we think that we'll come out of this session with a completely new stigma index. This is to kickstart the discussion around what could indicators and data collection questions look like that we can take forward to develop standardized and validated indicators to be used across the fast-track cities globally. But now it's time to give the word to the first presenter, who is Elena Vaughan. And Dr. Elena Vaughan is a senior postdoctoral researcher in the Health and Promotion Research Centre at the University of Galway in Ireland. And Dr. Vaughan's PhD research investigated experiences of stigma amongst people who are living with HIV in Ireland, and her postdoctoral research focused on specifically HIV-related stigma in healthcare settings. And she will be sharing some of her work and the process of developing indicators for these surveys. So she's joining us virtually. So over to Elena.
Everyone can hear me okay? Yeah, that's great. Okay. So thanks, Tanya. Buenos dias a todos en Sevilla. Good morning, everybody. I'm happy to be with you, albeit virtually from Ireland. As Tanya said, my name is Dr. Elena Vaughan. I'm a researcher in the Health Promotion Research Centre, excuse me, which is a World Health Organization collaborating centre for health research situated in the University of Galway in the west of Ireland. So as Tanya said, with the focus of this session being on HIV-related stigma and thinking forward to the development of indicators to measure stigma as part of the Fast Track Cities programme, today, I'll be sharing some of the lessons learned from a collaborative joint stakeholder project, which was carried out by our team in Ireland earlier this year, which is only recently just wrapped up. So hopefully this will be useful to those thinking about undertaking similar research and perhaps can inform future projects. So just to give you a bit of a roadmap of the presentation, I'll start by giving an overview of the project, of the whole project, before moving on to focus more specifically on the healthcare worker survey, and that's the one which measured stigma in healthcare settings. And I'm going to talk a bit about our experience with recruitment. I'll briefly present some key findings, but today's presentation is more about discussing some of the challenges encountered and the lessons learned. So that's what I'll focus on. So this project came around off the back of my PhD research into HIV-related stigma, as Tanya referenced, which was carried out in Ireland a number of years ago. And one of the key findings of that qualitative project was that for some of the people living with HIV who I interviewed, people were experiencing some stigma in the community and in families and relationships and so forth, but really it was in healthcare settings where there was almost a universal experience of stigma. But here in Ireland, we had very little data on stigma in healthcare settings, and no studies had been attempted to measure it in healthcare settings. So the idea then with this project was to begin to see how we could identify the issue, understand what was driving it, and work with people living with HIV and healthcare workers to lay the groundwork to begin addressing it. So the approach that we took was to ground the project in principles of participatory practice and really include stakeholders in the research process from the get-go. We also adopted an integrated knowledge translation approach in order to kind of kickstart the work of sharing findings and the knowledge generated throughout the research process. So the project was structured in a number of stages. Just to give you an overview, we started off earlier this year with a rapid review of the evidence on conceptualizing and measuring HIV-related stigma in healthcare settings. Following that, we then convened a stakeholder advisory panel. So the advisory panel was composed of 5 people living with HIV and 4 healthcare workers. The panel met virtually 3 times throughout the project. And really the role of the panel was to provide input into the data collection tools, so tweaking the language and suggesting relevant questions, for example, for the surveys or for the interview schedules, and also then to give feedback on preliminary findings and suggest ways of presenting these to the roundtable workshop, which was held later in the project. So we literally just wrapped up that roundtable a couple of weeks ago. So we collected data over the past summer. We carried out 2 surveys. One was aimed at healthcare workers and the other was aimed at people living with HIV. We also carried out interviews with a range of stakeholders, including people living with HIV, healthcare workers, community organizations, and policymakers. And then finally, we presented some of those preliminary findings at this roundtable workshop to a group of stakeholders, again, including people living with HIV, healthcare workers, service providers, and researchers. And the aim of that workshop then was to collaboratively generate suggestions for policy and practice recommendations. So there's lots that I could discuss, but given the topic of the session, I'm going to focus on the healthcare worker survey specifically. So following on from the rapid review of the evidence we carried out, we identified a survey tool developed by Nyblade and colleagues in 2013, which has been trialed and validated in multiple countries and across several different studies. So currently, this is the only standardized questionnaire for measuring HIV-related stigma in healthcare settings. The tool contains 18 core questions, which capture key identifiable drivers of stigma in healthcare settings at the individual and the institutional level. So these include things such as fear of infection, knowledge of stigma and discrimination, infection prevention measures used by healthcare workers, observed stigma, and then things such as institutional policies, training, and so on. We largely remain true to the original tool in terms of capturing those key domains and drivers, but we did have input from the stakeholder panel, so the language was tweaked in certain areas and questions were adapted for the Irish context, and we added in a question or 2 as well. So for example, we added a question on knowledge of U equals U of the advice of the panel. So just to talk about the recruitment strategy, so data were collected online via Qualtrics from the end of May until the start of August, so just over 2 months. Originally, we had thought to run it for a month, but there were challenges with recruitment, which is kind of one of the reasons I'm outlining the strategy that we engaged in here. So Ireland has a rather complicated healthcare system, for those of you who aren't familiar with it, and I won't go into too much detail, but in short, it's a somewhat fragmented blend of public, private, and voluntary providers. And so because of this quirk of the system, we really had to tailor the strategy to try and reach as many healthcare workers as possible. So this was a national survey. So part of those efforts included liaising with hospital group communication teams to put out advertisements through staff apps and newsletters, emailing invitations to university medical departments, professional organizations, and trade unions. We had to phone individual primary care providers in every county of Ireland We also engaged in a sustained social media campaign, issued invitations via WhatsApp, and also in line with our IKT strategy, our integrated knowledge translation strategy, we put out media pieces in local, national and industry media outlets. So quite a lot of work there, and I'll come back to that in a minute. So just to give you like a very brief overview of some of the fruits of that labour. So we received 378 responses altogether, and there was a completion rate of almost 80%. Some of the demographic characteristics of the sample are outlined there, and along with an infographic with some of the key findings, but just some that we can pick out that align to those domains or the drivers that I mentioned earlier. You can see in terms of training and policies, 80% did not receive training in stigma, 20% said their workplace, only 20% said their workplace had a stigma policy. In terms of infection, 40% would worry at least a little about drawing blood, and 29% would worry a little about dressing a wound of a patient living with HIV. In terms of observed stigma, a quarter had heard a colleague talking badly about people living with HIV, at least, or thought to be living with HIV at least once in the past 12 months. In terms of infection prevention measures, 13% said they double gloved. Just over a fifth then said they use special measures they don't use with other patients. So there's a few free text responses there that elaborate on that last point, included protective eyewear when drawing blood, end of day appointments, avoiding certain techniques or procedures. So really some stark findings there, and things that I think intuitively and through qualitative research we knew were occurring, but now we can have a more clear evidence base to say, yes, these things are happening in healthcare settings for people living with HIV. So in terms of the challenges we encountered during the process, I think recruitment really should be highlighted here. So uptake was complicated, I think, by healthcare worker burnout post-COVID. There were also some issues with gatekeeping, for example, with hospital ethics committees. And of note also, there was a competing survey. Actually, there was a Fast Track City survey being carried out at the time that we were competing with. Just complications of this nature, of course, can happen in research and do happen in research, but we had a very limited budget. So there was not a lot of flexibility in terms of staffing and no budget for paid advertisements, for example. And I'm not raising these points to complain, but just the key point is that future projects may need to factor these things in and ensure adequate resourcing to absorb potential project overruns, because it really is a challenging recruitment environment out there right now, I think. So despite some of those challenges, I think we can stand over the work that we did. This was the first national study to measure stigma in healthcare settings in Ireland, possibly on a national basis. I think it might have been the first in Europe. We did get good participation from a broad cross-section of healthcare workers, so I think those efforts paid off. And there was positive feedback, very positive feedback from stakeholders at the final roundtable. So we were very happy with that. There's of course limitations with any study. It is a relatively small sample size, which may limit generalizability. And we also had quite limited participation from primary care physicians, I think, which is unfortunate. But then just to summarize some of the lessons learned, this is probably one of the first projects I've ever worked on where multiple stakeholders told me over and over again that this was important work and that stigma in healthcare settings really needed to be addressed. So I think that really underscored the perceived importance of this issue. Given the 80% completion rate, I think it's a good indicator that the tool we used was feasible for the Irish context and was largely acceptable to healthcare workers. So this would indicate that there is potential, or that a similar tool could be used for national monitoring. However, I do believe that there would be methodological challenges involved, not least which would be deciding on how to frame a sample and get a nationally representative sample, which is obviously going to be different from country to country. I have to say the inclusion of a stakeholder advisory panel was key to the success of the project, and it certainly increased buy-in, relevance and knowledge translation opportunities, and knowledge exchange opportunities between the different stakeholders, for example, at that round table, which I think was a positive outcome. And lastly, just to underscore again that recruitment strategies require time, resources, and careful planning, and really need to be tailored to the individual structural context. So just thank you for listening to me, thank you for inviting me, and thank you for everyone who participated and supported the study.
To so much gear. Okay, right. Yep. Sorry. African context. So with us today we have Dr. Alanis Klöte, who is employed as a Chief Research Specialist, and I do have to read all of this, in the Identity and Belonging Unit of the Human and Social Capabilities Division of the Human Sciences Research Council. The other co-presenter, or the co-presenter, is Cindy Shangaze, who is a feminist and human rights activist with more than 20 years experience. She was also the project manager for the 2014 HIV Stigma Index of South Africa. So over to Cindy and Alanis.
Thank you very much. Good morning, colleagues. My name is Cindy. It is an honor to be able to join the space and be able to have a voice and share our experiences. I will just take a minute and allow my colleague Alanis to also introduce herself and be able to greet everybody. Alanis. Thank you, Alanis. And once again, thanks for this opportunity. Our session will be focusing on the lessons learned in adapting the Stigma Index 2.0 in the South African context. As mentioned, it's co-presented by myself and my colleague Alanis, whom we have worked with for many years, and they've supported us as organizations of people with HIV in developing our expertise in conducting research. So I'm really grateful that she's able to join us again today. A little bit of background. The stigma and discrimination against people living with HIV still remains a key barrier when it comes to designing effective prevention and management of HIV, in Africa, especially when it comes to young people and also women. You would know that in South Africa, we have more than 7 million people living with HIV, and about 5 million of those people are women. And the young women in South Africa are the ones who have the highest incidence. Yes. And with COVID-19, we all have experienced COVID-19 and key and vulnerable groups like people living with HIV have really, we've really been affected by the lockdowns. Services to healthcare centers was interrupted. about 640,000 people living with HIV defaulted during the lockdown in 2020 into 2021. So COVID-19 has really sparked a lot of fear as well in terms of prevention with the increased stigma and social exclusion. We know that the stigma index, was developed by various international organizations, which included the GMP+, ICW, IPPF, and UNAIDS. And the survey was supposed to assess different forms of stigma and discrimination as it is experienced by people living with HIV. As South Africa, we have participated in the 2.0 study version as well. And we will share our experiences from that perspective. Overall, we measured the levels of stigma and discrimination as it experienced by people living with HIV primarily. We also measured stigma and discrimination linked to TB, COVID, disability, sex worker, and sexual orientation, and gender identity through the cyberbullying. And this was important for us as organizations of people living with HIV in South Africa, because we are part of the National Council of AIDS in the country, and we sit as a sector of people living with HIV, and there are other sectors. We have 18 civil society sectors, which include disability, sex workers, LGBTIQ, people living with TB, etc. So it was really important for us to look at the vulnerability experience by key populations. And more importantly for us, it wasn't just, documenting evidence and providing numbers. It was also an empowering experience for the networks and for the local communities, as the HSRC had built our capacity to be able to understand how research is conducted, how data collection is done, how data quality is done, how to analyze data, and actually find the results, and how to write papers and publish papers. So the empowering aspect was really important for us. So in ensuring greater involvement of people living with HIV, we didn't want it to be just an extract, study that we do in the communities where you come in. So our idea was that the interviewer and the interviewee are peers. They will sit side by side when the interview is being conducted. And the questionnaire, when it's being filled, the interviewee will be able to see what the interviewer is writing and even guide how to frame their own voice and their own experience, which is very different from a traditional face-to-face interviewing that is normally done in surveys, where you would have the interviewer on the other side of the table with the questionnaire, and the interviewee cannot see the questionnaires, cannot even see the responses that are being written as their own. So, which is disempowering. And then the key measures that we looked at in terms of are the indicators in the study. We'll just mention a few. These would include the issue of disclosure, the experience of stigma and discrimination, and the internal form of stigma and resilience as well. The interactions in healthcare facilities when accessing, different services, including sexual and reproductive health, TB, and COVID services, human rights, and effecting change. So these were key for us. The questionnaire itself had questions that focused on specific populations to better understand the different groups of people living with HIV and how key populations are affected by stigma and discrimination. And we also did an extended health session to look into the impact of stigma on health and access to health care across the whole continuum of care, not just HIV, because we believe in providing we believe in comprehensive services, and we've got a national strategic plan that looks into grounding responses in human rights. So that was very important to ensure that we look at the continuum of care. And the new questionnaire was streamlined and easier to use using the digital data collection, as you can see the link. And then in terms of measurement, in terms of time, I might not go deep into each of the indexes, but you'll see that Section C focused on the experiences of discrimination in the last 12 months in the event where, particularly around social spaces like gatherings. There are a lot of gatherings that happen on a regular basis, like weddings and funerals, and people were supposed to take how often they felt, discriminated or stigmatized, whether it was once, a few times, often, or never. And then in the 2.0, so that was the 2014 stigma index. And in the 2.0, it just went a little bit further. It's not just questions posed, but also where respondents must answer yes or no. The interviewer and the interviewer relationship can be disempowering, and use statements counters this more streamlined. So the indicator here will be percentage of people living with HIV, age 15 and older, who report experiences of discrimination in general in the last 12 months. And then on Section C, which was more about internalized stigma, then we would look at the percentage of people living with HIV against same age group who reported internalized forms of stigma and resilience in the last 12 months. And then on Section E, it would be the interactions with the healthcare services. That would include availability of services, but also just interaction with the healthcare workers themselves. So they would look at the percentage of people living with HIV, same age group, who have experienced stigma and discrimination in the last 12 months. As we know, that the session is not focusing on results, so I always have to stop myself and remind myself that I'm not presenting the results, but I'm so inclined to just want to share what the results were. But I will stick to the briefing. So the processes of adapting questions to the South African context, we had a process of engaging with the researchers through the Human Science Research Council, and we also worked with the SANEC Trust so that we could embark in a process of learning which indicators are relevant in promoting human rights to end stigma and discrimination. And that would mean we work with the 18 sectors that I had mentioned, but then focus mostly on sex worker, disability, people living with HIV, people living with TB, etc. So in addition, with the pale HIV sector, recommendations were made, and those recommendations included that we need TB-related stigma to be measured, COVID-19 stigma, and access to healthcare facilities during COVID specifically, and also the issue of cyberbullies, as we know that there is a strong component of young people, adolescent girls and young people. So what are the lessons learned? Taking into consideration the high burden of HIV and TB co-infection in South Africa, the next stigma index 2.0 should consider expanding the issue beyond the feelings of dirtiness and uncleanliness when it comes to measuring, TB experiences. For example, did a client experience internalized feelings of shame, isolation from society, and fear of discriminatory practices because of their TB status? Another example would be, was there greater stigma experienced by persons with drug-resistant TB, multi-drug resistant TB? And finally, did the TB-related stigma impact and clients' willingness to interface with the healthcare system? So we feel that is important, but in a more specific way, more research is needed to further refine the national understanding of stigma and discrimination amongst key populations. We need more understanding of stigma and discrimination amongst key pops in terms of the language used, which can be a barrier. We also needed more advice as to what would be specific questions that would inform the indicators. So that will be our work going forward. Due to time, the presentation was very short, but we hope that it will be helpful. And thank you once again for this opportunity. My colleague Alanis is also available. Alanis, would you like to come in?
Hi, Cindy. No, I think that you've done justice to the work that we've done in terms of adapting the Stigma Index 2.0 to South African context. And it's really the participatory spirit and the collaborative nature that we've done this work with the sector, not only the PLHIV sector, but disability sector, sex worker sector, and LGBTI sector, that really push this work to an understanding where it encapsulates people living with HIV's experiences of stigma and discrimination on the ground. So that is just, my sort of final concluding remark, that that our partnership and our collaboration in this work is what in the end makes this impactful and meaningful. Thank you.
Thank you very much, Cindy and Alanis. We have one more presentation. This is a live one, in person. So I'm happy to welcome Gary Braw and Steve Worrell, who are both members and community representatives of the London Fast Track Cities Leadership Group, particularly working on the stigma workstream. And they're going to share about their experiences of measuring stigma in London. So I think you get all the gear now.
Can people hear me online and in the room? Online is more important because I can shout in the room. So let me just check that good morning. My name is Gary Brough. I'm the community representative on London's Fast Track Cities Initiative Leadership Group. And my colleague Steve is the NGO representative for Positive East, one of our HIV sector charities in London. And just a quick overview. The thing to mention is that the link at the bottom there is the reference for the National AIDS Trust survey, the Public Attitude Survey, which is what we're looking at in terms of the data around where societal stigma relates to. And so it's a very full and robust document. It'll give you all the information and the questions that we used in the survey, both nationally as well as then a London perspective at the end, which is what I'll come to in relation to the questions at the end of the presentation. So when we started in London in 2019, we formed a stigma subgroup that was chaired by community, so myself and the NGO reps, and we started to think about what we were going to be delivering around addressing stigma. We brought together the HIV voluntary sector organisations and people living with HIV right at the start of it, in a full-day workshop to really explore the issues around stigma, because there was a recognition that centralising the voices of people living with HIV in the response was the way to start the process, and that had to be the way that it was going to be run throughout. And so from that day we put together proposals and the decision then to fund a survey to look at public knowledge and attitudes. National AIDS Trust have been doing that since 2000, every few years, and so this was the latest iteration. So the survey was published, and as I say, you can find all the detail within the PDF, which will be shared afterwards. And then we developed a community of practice in order to have the internalized stigma work led and delivered by people living with HIV, as well as then to think about how we measured the successes and the developments in relation to addressing internalized stigma. A second part of the community of practice and the empowerment program was to develop an ambassadors training and program so that we could have lived experience when it came to addressing stigma in places and in the public, since we recognize clearly that if you're going to talk about HIV, having people living with HIV be the voice of that campaign is really key. It's the humanizing of a condition that makes the connection with people. And so we've launched the empowerment program, and that's currently running. We're also working in the same way that Galway have on a stigma survey, which has been piloted in Barts and is going to go wider around London and nationally. And then we will be developing the HIV-friendly charter, which is the idea of how we address stigma in places as a result of the survey work that we do. And that's currently out for tender in London, with the idea that it will be led by the voluntary sector in order to be able to, as I say, ensure that the people living with HIV are at the core of the process. So the way that we're looking is that three layers of stigma. So from internalized stigma or self-stigma for people living with HIV, addressing stigma in places where people will go to access support, starting within the NHS, thinking about local government, and then moving wider to societal stigma. And so these 3 points there talk about that idea of how we move from one to the next. You can't really challenge one without the other, that's the thing. And I think the whole point for us with this was starting with people living with HIV was very key. Taking it into the places where we access care and support was crucial. And then moving that into the public sphere was going to be the final part of it.
Gary, sorry to interrupt.
Yeah.
No one online can see your slides. So can someone in the room please switch the camera just so that we can see Gary's slides?
Apologies. I wasn't aware. It's up on the screen here. I thought you had it as well. Thank you for letting us know. The slides will all be made available straight after this, though, so you can get up on my. Sorry about that. So I'm not going to spend a lot of time in relation to the work around self-stigma because those programs are up and running, and they're running with different communities in different places, and looking at different key populations in particular. But what we are now developing is that last point. To develop the ambassadors training and to bring together a diverse group of people living with HIV who can then work when it comes to the HIV-friendly charter in addressing stigma in places, as well as then the public campaigns that we'll do to address societal stigma so that we have the voices and the images of people living with HIV to really combat and address stigma. Okay. So similarly to, as was already mentioned in Ireland, we've already started a survey and that's been piloted. And then we're going to be taking that wider across the another two healthcare trusts. But that will also then go national to really think about how we link up with the other fast-track cities in the UK. And it'll look at knowledge and attitudes of staff, which will also then be a part of the process around informing the HIV-friendly charter. And so this process then will allow us to think about how we give people the opportunity and the places the opportunity to engage with learning and education and to be able to have the tools to be able to report stigma, since clearly one of the challenges that we have is that people often don't come forwards and talk to us and tell us what's going on. And so the key organizations in London will be there to be able to filter that information through a trusted resource to then be able to address things more broadly and specifically within the settings that we're talking about. And so lastly, and most importantly, the societal stigma piece, we're currently tendering for a 3-year contract for an HIV-friendly charter which will address the stigma in society as well. So with the charter program that addresses the stigma in places, we've operated in a similar way to a current initiative called the Zero Suicide Alliance, and that was a mental health charity alliance that was working to address mental health issues. And so they did a training that they deliver for places, but then it's open to the public as well. So that process then takes the knowledge and understanding, the questions and the challenges from the places where people access care and takes them to the public. And so for the Zero Suicide Alliance, it's had over 300,000 people take the survey and the education piece. And so if we join that information and the surveys and knowledge with the experiences and the interviews with people with lived experience, that is how we think that we'll really start to address societal stigma. And obviously, we're not working in isolation, we're working in partnership with all of the other UK cities. And so each of them have slightly different ways of doing this, but what we're looking at is as we work together to validate the tools that we're using and to see the benefits that we're getting, that we can then have something that challenges stigma nationally rather than just within those cities. And so the idea then is to take the areas of work in some way in the layers of an onion. You start with the individual, you go into the places that they access support, and then you end up in wider society. And just to end with a couple of the points from the survey that we did around public attitudes, I don't want to preempt the conversation on the tables too much, but I'll give you an example of a few of the questions that were asked in this that relate to then experiences and judgments and moral judgments from people. What came out from the survey was that it was very clear that most people don't think or hear about HIV. There was over 80% of people recognized and felt that there was a degree of negative attitudes and stigma towards people living with HIV, but they didn't actually necessarily recognize their own stigmatizing views. And so some of the questions that really flagged up where you see this issue come to life was there were questions around whether having somebody that you know diagnosed would affect your relationship with them. And so the areas that they covered were a family member. Would a family member's diagnosis have a negative impact on your relationship? Would finding out that a neighbor had HIV have a negative impact on your relationship? Do you think that your employer should tell you if one of your work colleagues is living with HIV? Is one of the ones that came up as quite clearly an issue of stigma, because most people felt that, yes, I have a right to know if a work colleague has HIV. But I think probably for me the most fundamental one is, would you dare to have a sexual relationship with somebody who is living with HIV? And when you look at the figures for that in the UK and in London, there was really only 2% that said yes, they would be comfortable having a sexual relationship with somebody living with HIV. And so I think, it gives us an idea of the areas that we need to work in, the challenges that people face around talking about HIV and the anticipated responses they're likely to get. And so hopefully this will start the conversation in thinking about what are the questions we need to be asking as a standard, as part of the workshop session. Thank you.
Thank you so much, Gary, and for sticking to time beautifully. Closing the presentation part of this satellite session, we have José Zuniga, the President and CEO of IAPAC and the Fast Track Cities Institute, who will say a few words about achieving zero from the Institute's point of view. José?
Thank you very much. Pleasure to be here with you, and we're really thrilled to be hosting this session on stigma and specifically indicators, because very clearly you cannot fix what you cannot measure. And one of the hallmarks of the Fast Track Cities initiative since its launch on World AIDS Day 2014 was that it is data-driven, equity-based and data-driven. But unfortunately, in many jurisdictions, indicators are not either used or available. So I'm excited about this discussion because, as we all know, stigma kills just as much today as it did more than 40 years ago when silence equaled death. So finding a way of eliminating not just HIV-specific stigma, but intersectional stigma is clearly a significant challenge in closing the gaps that remain across the HIV care continuum, but also in trying to scale up prevention activities and in attempting to address the incredible inequities that exist in our healthcare systems. So where does our focus lie with the Fast Track Cities Institute? Well, first, and with IAPAC. First, there is a remarkable amount, sadly, of stigma and discrimination being perpetrated within healthcare facilities. We know that because we've measured it. We know that because we've spoken to people living with HIV and those who are affected, who identify this issue as one that serves as an incredible barrier to accessing and utilizing HIV and other health services. So our focus there is largely to build capacity within the broader medical community, especially as HIV treatment becomes much easier to administer, especially the primary care community, to ensure that they are aware, for example, of U equals U and promoting that message as far and wide as we can. And even where there are pockets of resistance to U equals U, to advocating, utilizing thought leaders amongst the medical associations, the nursing associations around this issue. But also key is having data, and as I mentioned, this is a data-driven initiative. And in that respect, last night, mayors and deputy governors and governors from various fast-track cities around the world signed the Sevilla Declaration on the centrality of affected communities in the urban HIV response. Within that declaration, not surprisingly, we speak to the importance of eliminating stigma in all its forms perpetrated against people living with and affected by HIV. But as important, there's a specific commitment within the 10 to the issue of data. And so there, the work that you are advancing here and in your respective fast-track cities is incredibly critical, because just as we struggled at the beginning of this initiative to entrench the 90-90-90 targets, some of you will recall how challenging that was, within HIV responses at urban level, entrenching stigma indicators and ensuring that they are implemented and that data are being reported transparently is absolutely critical. And there too, beyond indicators, I think there's a significant element within the Sevilla Declaration that speaks to community-led monitoring. And that is supplementing official data sources with data that community identify themselves, whether it's the stigma index or some other indicators, creating the space for community to be an equal partner in data generation, data analysis, and as important, actioning the data to us is extremely critical. And so we're supportive of your efforts. We want to learn more. I know that Tanya will be in touch with all of you and more of the fast-track cities globally as we try to advance this activity. But I'd close only by saying that amongst our many priorities as a Fast-Track Cities Institute is the Zero HIV Stigma Day that was announced this year. It will be held every year going forward on July 21st in honor of the late activist Prudence Mabella. There are a series of activities that are being planned around this important day. And why did we decide to launch it? Because there wasn't one. And I think that speaks to how unfortunate it is that stigma and discrimination has become, eliminating it has become a slogan. We need to change that dynamic. We need to understand and have others understand that it is the largest impediment, in addition to inequity, in addition to inequality, that is stopping us from ending the HIV epidemic, which we can do. We have the tools at our disposal. We have the creativity. We have the energy. It's here in abundance. But we need to be honest about the fact that we have a barrier in front of us that is persistent. It's long-standing. It's been ignored in many quarters, not by you, but it's been ignored. And so now's the time to raise a volume around it, and it's important to do something about it. Thank you very much.
All right. Let's see. So, thank you for listening attentively and bearing with some of the technical hiccups. Now we will move into the novel and more interactive part of this satellite session. So as mentioned in the beginning, we will have roundtable discussions around indicators and data collection questions. So a few roundtable keeping notices now. Some of you have been asked to already sign up for the roundtables in advance. So the roundtable, there will be 2 roundtables physically, 2 virtually. The roundtable on stigma experienced by KPs is here. So kindly, if you signed up for that roundtable, move here. It will be moderated by Gary and Steve, so it's there. If you signed up for the roundtable discussion on self and internalized stigma, the roundtable is there. So kindly move there. For the rest, you are in no way being excluded. It would be a bit abysmal in a session about stigma and discrimination, wouldn't it? So, for the ones who haven't signed up for roundtables in advance, I invite you, or we invite you, to, in your tables, choose a focus. So one of the domains, so we have 4 different domains. One is about stigma in healthcare settings. One is stigma experienced by KPs. One is self and internalized stigma. And one is on stigma in the private sphere. Now, at your table, we then ask you to discuss a potential indicator for your stigma domain. So if you now choose to focus on stigma in healthcare settings, I have an example here. A potential indicator could be the percentage of people working in institutions who are uncomfortable working with or treating people living with HIV. Associated data collection questions could be the ones that are lined there. So the roundtable discussions will be for about 15 minutes now, since as per usual for a session we've gone a bit over time. Then we will come back in plenary and ask each of the pre-organized roundtables to share their indicators and data collection questions, and then take feedback and reflections from the room. So again, if you already signed up for the roundtable on stigma experienced by KPs, kindly go to this table. If you signed up for the one on self and internalized stigma, kindly go there. If you didn't sign up for any, choose a focus with your roundtable mates and discuss indicators and data collection questions. And we will resume in 15 minutes.
Good morning, good afternoon. I do believe that this is our group.
Hello. Everybody. So which breakout room were you supposed to be in?
I'm supposed to be in healthcare settings. Yeah.
I'm supposed to be.
Okay, I have the feeling this discussion could and should go on for much longer, but as declared in the beginning, the intention is to kickstart the conversation. So just before we get into the roundtable presentations, I do ask that if you're interested in targeted follow-ups, please leave your contact details if it's not already on the list, so we can follow up with you as a group. But as said, we want to hear from each roundtable now what you discussed and potentially came up with. And sorry, I'm giving the school teacher stare. Okay. And I would like to ask the roundtable that discussed stigma experienced by KPs to start. Keep it short and succinct. Yeah, can we have a mic, please? Not this one, the handheld one. It's not here, unless my phone. Not, you have the handheld mic? I want the handheld mic. And just checking, can everyone online hear us as well in the Zoom? Can I get a virtual or thumbs up? Excellent. Okay.
Testing, testing. Can you hear me online as well? Give me a thumbs up there, thank you. So we've had a wide-ranging discussion. I think from the British perspective, sex seems to be the thing, but that, it all comes back to sex, has come up several times. And so it's difficult. I think the point is with this is that there can't be one key indicator that you're going to need to be able to think about a range. And some of the things that came up really were particularly around moral judgments, but then understanding and awareness of what HIV is and what treatment means today are key questions to be asking in relation to finding out whether people have confidence in their understanding of treatment, U equals U, and what it means to live with HIV today. But we couldn't come up with a single specific one that we wanted to prioritize necessarily. So I think the thing that came up most was just the fact that there's a whole range of things that need to link in, and there was general agreement that a lot of the ones that we talked about from the survey actually came up within the group as well. So maybe it's one of those things to look and to compare the surveys that are being done globally, and to think about how we might pick the best and do some kind of a prioritization exercise for those. That's my thoughts. I'll pass back to Steve. Yeah.
I mean, there were a couple of themes we just want to highlight, though, and one was actually what do we mean by community, and what do we mean by population groups? One of the themes that came up was what is the sense of community that we're trying to understand, and then what would be the barriers at a societal level around that, because society. Okay, we're back on again. Yeah, technology. So yeah, when we're talking about society, what are we actually really talking about was one of the issues that came up. The other thing was actually stigmatization within communities themselves, and the idea of a double stigma. So you can be associated with one particular part of the society, but who you're identified as also then can be a compounding factor. And so actually thinking about societal change is complicated around that. And the other theme that came up was, how do you put this into a human rights perspective? One of the themes and an interesting question that came up is, do we deserve to be stigmatized, and what messages actually comes around, and how we actually change society's attitude is actually challenging that, is that nobody deserves to be stigmatized as a starting point. And then the other one that came up, if we're going to change society, if we're going to change things, and this would be an indicator, is what language are we using? Do we actually understand what we're using by the terminology amongst ourselves as HIV professionals, and then how would the community itself understand whether we're talking about treatment as prevention, U equals U, whatever it might be, and it's about, do people actually then trust the message that's coming out? Hopefully that reflects what people are saying around the table.
Thank you. Just while we get the technical setup, I will ask Alfred Xavier's group to present next. They're talking about stigma in the private sphere, and Alfred is presenting Fast Track Cities Antonio. Do we have Alfred with us? Oh, Dash? We do not, so we go to the other in-person roundtable, which is over here, self and internalized stigma.
Okay, are we on? Yeah, thank you. Okay, so what a rich discussion we had over here, and I was trying to capture it. It was very interesting. So we talked about, the complicated nature of internalized stigma, because it's not just about living with HIV. You're an individual with multiple interesting aspects of your personality and your being. And so when we talked about what we were going to measure, we talked about the emotional and affective aspect. It's difficult to properly or structurally measure these things. We talked about anger, lack of compassion, fear, the kind of forces that create and sustain stigma. We talked about societal versus internal stigma, and that actually you can have internal stigma even as a group. So it's broader than just the individual as an individual all the time. Some of the determinants had to do with perceived severity, responsibility, norm violations, anger, experiences of burden. Some measurable items would include levels of testing, engagement in community, etc. So our sample indicator would be the number of times one has excluded oneself from activities or community. And some questions we thought of were, how close were you before you were diagnosed, just to make sure that we could exclude, you're being a shy person anyway. But also, I think my HIV status is or is not a barrier to achieve my goals. I feel extreme fear, anxiety, or anger as a result of my status. I feel empowered or able to address any issues regarding my health and well-being. How do I engage with others given my HIV status? I feel other factors regarding my identity impact the way I feel about myself to address the intersectionality. I think, we had some discussion of how one feels when in a medical setting and you're aware of the fact that somebody is using extra protection, or you're aware of the fact that you've disclosed your status and now you're being put in a particular place in the queue, and that being something that you are perceiving. Let's see, do I feel shame, disgust of myself? I don't like going to healthcare. Some experienced versus anticipated stigma is important consideration. Behavioral markers, perceptions of complaints. Do I feel that I can complain? Do I feel that I have any kind of recourse? Am I able to challenge any discrimination? Yeah, and we also had a little discussion about the fact that perhaps we should be also including positively framed questions instead of just negatively framed questions in order to start to change some of the trajectory of this. So I think that can be considered when actually forming the questions. Feelings of burden, difficulties in establishing intimate relationships, experiences of anxiety, fear, and stress, I think, they think kinds of questions. This was all part of our discussion. That's it. I think.
Well, again, if we go back to my school teacher days, I would say, well done. You actually did you came up with a concrete indicator and concrete questions in a very short amount of time. As we are still experiencing some hiccups with the virtual roundtables, I would invite feedback to each other's roundtables of the ones who are in person. Any thoughts on the concrete indicators presented here or the data questions?
I'll do the mic service. There you go. I said, this is for a little bit for everyone. I was just really asking, I think everybody kind of answered it though. Was it a very difficult task to narrow down a focus for each of your groups? So no. And what made it not difficult for that group there? Because I need some pointers. They were great. I need some pointers.
Does anyone want to take on this question? What made it easy for you to, let me give it to the team I was co-facilitating here. What made it easy for you?
I was being slightly ironic, but it's just great to be at a table where people actually seem to, I think about the narrative about making it change to a positive frame is really does require us to consider how we look at it objectively. I think HIV stigma is a very real and very potent and hellish thing in many places for many people in many ways. But I think, we know from black spaces, gay spaces, religious spaces, that representation is all. And when we start seeing people living with HIV, whether it's by virtue of being engaged in a healthy, high-quality peer mentorship environment, that may be a good indicator. Have you experienced a healthy peer mentor context to support your growth? I think, we have to start really looking at how we're asking these questions, because if you want to go mining for shit, it's very easy to find shit. And I think there's better ways of doing this by being positive as well as the negative questions have to be considered. But I think it's really critical that we start thinking about positive frame, because many of us living with HIV are doing it in a way that's functioning and healthy.
At the point where we started, he very clearly also just reminded us of the fact that we needed to avoid overgeneralization from a lazy perspective. And I guess, I don't remember the exact words you used, but it was just us being conscious of not just, umbrella terms and having a very sharp, measured approach rather than just lazily generalizing.
Thank you. I think maybe another difficulty was to really bring it to the personal level and the internal level.
I think it's easier to do indicators based on what's out there to say this is what's happening, but to really say how do I feel and is this real or perceived because of various other external and societal factors. So that was the difficulty to really be internal about it. Thank you.
Sorry, I'll just cut the comment short because we do have one of the virtual teams with us now.
Okay.
So, Elena, would you like to present your group's discussion on that was stigma in healthcare settings?
Well, I'm afraid we had a lot of technical difficulties and we only managed to facilitate a conversation of about 2 minutes. So we didn't get to developing indicators or questions really. I suppose we kept being muted for some reason. So we had a lot of technical issues. We didn't have a lot of time, unfortunately. I suppose a couple of things that did come up in the very brief conversation that we had is in terms of looking at stigma in healthcare settings is a focus not only on quantitative indicators, but perhaps on implementing qualitative approaches. So, Catherine, one of the suggestions that Dr. Catherine Dodds gave was, we could try approaches that would include an audit of policies and tracking their changes over time. Briefly, we also discussed the importance of addressing stigma towards key populations in healthcare settings. This might vary from country to country, I think, in terms of the cultural context, but that would be an important focus. And I suppose then we again, very briefly touched on, related to this issue of stigma towards key populations, is linking stigma reduction efforts in healthcare settings to broader societal efforts, because healthcare workers, of course, are members of society like everyone else. So there should be some coherence or some link between those two efforts. So unfortunately, there's not much more I can give you based on our discussion because we were hampered by those technical difficulties. So apologies from our group. We didn't get very far, I'm afraid.
That's perfectly all right. It was also a short time frame, and with the technical setup, even more challenging, but we will follow up. I also see Dash and Alfred, who were representatives of the other group on stigma in the private sphere. Dash or Alfred, would you like to share?
Yes, can everybody hear me?
Yep.
So ours was within the personal sphere, and same thing, just due to limited time. Some of the potential indicators were the level of comfort that someone may have in disclosing their status that could be tied into either self-confidence or the level of trust, self-stigma within a person, internalized stigma, attitude towards having a relationship with someone living with HIV, or the level of health literacy, which also turns into the level of trust to be able to disclose. But the one that we focused on was any potential measure in attitude change towards having a relationship with someone living with HIV, and then the data collection questions would be personal relationship different than sexual relationship. Our group believed that there's definitely a difference in potential attitude change if it's a personal relationship as a family member, a friend, versus a sexual relationship. So I want to thank our group for being able to help out and come up with these topics.
Thank you very much, Alfred. And I'm very aware that we have another session starting, but I just want to say I think it's very clear from both the presentations and discussions that despite our many years of experience with working with HIV, with our different expertise areas, whether it's clinical, community, public health, we still tend to get stuck on process and importance when we're talking about stigma and actually breaking it down. So I think these discussions, as well as the presentations, have illustrated how difficult it is to actually get concrete, right? We get so stuck on what areas, what domains, and then once we've identified them, we don't really get further. So clearly there is a lot of work to do in terms of developing indicators, developing data questions, and as I said, if you are willing to be contacted for targeted follow-ups, please do leave your contact details if we don't already have them on the table. And we will be doing follow-ups so we can progress on this work, which was just kickstarted here today. But I thank you for not just bearing with, but embracing this somewhat hybrid format, new format. I hope you've enjoyed it, and I look forward to engaging with you for the rest of the conference. Thank you very much.
Thank you so much. Yes. Really bright light, haven't we? Almost blinders. Good morning, everyone. Sorry for the delay that we are running into in this session. My name is Gonçalo Lobo. I'm working with IAPAC now for 2 years, and I'm also co-leading the project on the Cohort of Champions. Alongside with me, we have the City of Amsterdam with Elske and Maria Prins, and also to my right, Professor Jane Anderson from London. Unfortunately, our colleagues that are also part of the steering committee of this project from Kyiv are not able to join us due to the recent events in the Russian-Ukraine conflict, but they are with us in thoughts. So we would like to go through with you on today's sessions on the Cohort of Champions project. Professor Jane Anderson is going to give a brief overview of the concept that we have developed for almost 9 months now, and then also what's coming next and what are we tapping and looking into. So Professor Jane Anderson, the floor is yours.
Thank you very much, Gonzalo.
Okay. 1, 2, ooh. Okay, it works. This is very loud. Okay. I'm here on behalf of all the cities that are taking part in the Cohort of Champions initiative and representing the steering group, which is a group of us from London, from Amsterdam, and from Kyiv, with Vive Healthcare and Fast Track Cities initiative also part of the group. My disclosures are there, and I'm going to talk today about this project, which is a European Cohort of Champions, what it's about, why it's happening, and how, when we're going to make it work. It's about collaboration, it's about partnership working, and in particular, trying to find ways to share best practice, to build resilience, and crucially, of course, how to optimize outcomes. So this is something we all know, but it's worth, I think, just repeating again. What are the pillars of an effective HIV response? We know what they are. We need to be making sure people living with HIV are diagnosed as early in infection as possible. We need to make sure that treatment is quick and effective. We need to make sure that support is there all the way through the life course, throughout the HIV journey, for all the other things that people living with HIV face, for comorbidities, for emotional support, and all the things that we know really matter. And if we're going to prevent, we have to use all the tools at our disposal. We know that, and that's the basis of our cascade. Every single one of those pillars, however, is embedded in concrete. And the concrete is the personal, the local, the national, and the global context. And that is different in every place and for every person, and people are all standing in different shoes. But of course, throughout the whole thing is political will. And if the political will and the political pillars are also in the right place, and the policies are in the right place, then the pillars will stand firmer and the work will happen much more easily. So we're looking here at both diversity and consistency at the same time. Now, Gonzalo asked if I would just try and focus this in the bigger picture, and I think it's really important because, of course, we're here at Fast Track Cities HIV, but the world is in a really interesting turmoil at the moment. There are so many other things that are impacting on health and well-being, and HIV is part of a bigger picture, which we absolutely have to take account of if we're going to make the difference we want to make. So we can start off thinking about Europe. It's huge. We've got 74 countries in Europe. We've got 743 million people. You can just see from the colors how many different states, places, nations there are. And just over half are in collaboration in the EU. And of course, thinking about those collaborations, that's really important. There are 27 countries. It is to my regret that there are not 28. I would like that to go on record. I feel very sad about that. And we are there as a small grey patch. However, there are 27 countries aligned together. And even then, there are other alliances with the Schengen Collaborative and other things. And the important thing here is this freedom across these purple countries of people, of goods and services, and within that, of course, health services. So we've got this really complex state of affairs. But if we think globally, there is a Sustainable Development Goal 3, and this is what the world has signed up to. The enjoyment of the highest attainable standards of health is a basic, fundamental human right. And if we hold that and we continue to argue from that perspective and really hold on to that, then some of these other differences get into a different context. But there is a commitment globally to ensure healthy lives and to promote well-being for everybody at all ages. And I think that's also really important for us to remember. But if we think a little bit about what that might look like, I've got a graph here, thank you to Gonzalo for helping me with this, about life expectancy at birth between 2013 and 2018 across Europe. And you can see on the left-hand side, if I can make my pointer work, that you've got the EU 27 there and variability across the piece. But importantly, let's dig into that, and I'm going to use an English example here. This is data that has come, the graph is courtesy of the King's Fund, but this is national data looking at a fall in life expectancy. And this is between 2019 and 2021 in England. Now you might say, yeah, well, there was COVID, there were lots of other things going on. Of course there were. But the point of this graph, which shows men in dark blue, women in lighter blue, I want you to notice the change, the fall in life expectancy, nearly 2 years in the most economically deprived areas, and how that changes when we look at the least economically deprived areas. This is the impact of economic deprivation, social deprivation on life expectancy over 2 years. Now, COVID, of course, has highlighted that, but as we move forward in this new era, with the economic turmoil that we're facing, we have to understand that we're living in a world where the impact of economic change on health and the projects we want to do together and the things that are going to make a difference to HIV are being fundamentally affected, and that disparity is really important. And of course, we're all in different health systems. So even though I show you a graph where there's lots of purple and people are linked up, the way health systems deliver is also very different. We have socialized medicine, some of which is publicly funded and publicly delivered, and we have that in the UK and in Spain. Other areas, the funding comes from employers and is privately delivered. Other places, you have an insurance model, private delivery, public funding. And to be brutally frank, there are huge areas of the world where people just pay or not. And that is true in our continent as it is across the world. So as we talk about how do we achieve the goals we want to achieve, this is our international context as we're going forward. Are people satisfied with what they're getting in terms of healthcare? Not too bad overall. You can see the European average in the red bar in the middle, and even the British NHS, which is 2 to the left, which has been our national treasure, there are still people not able to access what they need, and that's 2020, admittedly pandemic. But there are a lot of people in Europe who are not satisfied with the availability or quality of healthcare where they live. That's generic. That's before we even start to think about HIV. So HIV in Europe, what are we thinking about here and what do we know? And I think the key message for all our cities, for all of us, is we need to know our epidemic because everybody is working in a different context and HIV is manifesting in different environments. So I pose the question to all of you, from whichever cities you're from, do we have the data we need? We have amazing global data from UNAIDS. The regional data from Europe, fantastic, ECDC doing a great job with the HIV-specific data, both for the EU and for the WHO Europe region. I give the example of the UK, England, where we have our official statistics, which have just come out, dated October 2022, but because of the staffing issues and COVID, those are reporting data which is actually almost 2 years behind, unusually for us. But nonetheless, if we are to make the difference we want to make, have we got the data for our cities? And in particular, within our cities, have we got the data for our populations? Because we know in London, even though we've met our 95, 95, 95, there are parts of our city where that is not the case. There are parts of our city where there are still people being left behind because we maybe don't have the specificity of the data we need and the populations within that. And I also wonder, and this is a topic we've been talking about at other sessions at this conference, about community monitoring initiatives, community-led data from particular populations, and of course PROMs, patient-reported outcome measures. Are we using those in our clinics, in our cities, and have we got that data at a person level? And I pose that as a question. But I have got a bit of data which I think just really to sort of illustrate some of these big points. If you look at what's happening in the WHO region, people newly diagnosed with HIV, the numbers have been falling. That's really encouraging, very exciting. And the same is happening in the European Union. So the big picture, things are going in the right direction, but I ask you to note that is still a year ago, and there's a lot of things have happened since. Now, I know you're all going to want to read the names of the countries down the left-hand side. Please, that isn't the point of this slide. The point is the pattern of colors on this slide. Because this is showing the people, the population groups that are particularly represented by new HIV diagnoses in each country. And it's showing you in turquoise men who have sex with men, dark green, heterosexual men, pale green, heterosexual women, navy blue, people who use drugs, and grey, classified as other, which I think shows another thing about data and have we got the right information. But what I'm trying to show you here is that countries are different, they have different populations, different expertise, and if we are to learn from each other, then we need to find the partner in the country that maybe has the experience with the populations that we may be grappling with. So it may be that the countries and the cities who have large populations of drug users are able to offer help to those of us who have a much smaller population and where we can exchange knowledge both ways round. And again, patterns. This is all about patterns because we know, if we go back to those pillars, diagnosing HIV in time is one of the most crucial steps in people having a long and healthy life with HIV. And again, you don't need to look at the specific numbers, but the smallest number, this is people who are diagnosed late, even in Europe, even with our fabulous health systems, even with all the things that we have, the smallest number there is just under 40%, which really is quite shocking that people are still being diagnosed with late HIV. And then if we unpick that, and this is across our continent, we are looking at people who are older, we're looking at people who are acquiring HIV, men acquiring HIV through heterosexual transmission and women, but actually diagnosing late remains a problem. And there are lots of initiatives in place, but this is still the colour chart that I want you to hold in your head as we go forward. So what do we do to try and bring some of this together? And the Fast Track Cities Institute put together the idea of a cohort of champions. And this is the initiative that I'm going to tell you a little bit more about. But as we talk about it, please hold in your head all that background that these champions, these cities, are in this complex and interestingly different environment. So we've got amazing numbers of fast-track cities in Europe. And obviously we have to talk about Spain. To have more than 100 cities, wow, that is kudos, kudos, kudos. And last night at the signing ceremony of the Seville agreement, the numbers of cities who were coming forward to sign was incredibly spectacular. So here we are in Seville, in a country where fast-track cities is something that many people know a great deal about. We have France with 12, Portugal 11, UK, there are 8 cities. We're absolutely delighted that Birmingham joined less than a week ago, I think. They've been trying for 4 years to become part of the partnership, so we're delighted to welcome another city. And Italy has got 11. Now that's great, but there are many countries that don't have more than one. And so some of those countries have one city trying really to do this work without necessarily support from other cities in their area. So the Czech Republic, Poland are amongst examples there. So in the UK, for example, we've now got a nice network where we actually can talk to each other, but not every city has that. And that's a really important point here. So some of this partnership working may be particularly important in places that don't necessarily have near neighbours. So the cohort of champions is intended to establish a community of learning. And a community of learning means bringing people together, to learn together, to share learning together around a common purpose. And it's based on twinning partnerships across 20 of Europe's fast-track cities. Now, in London, we have recently established a community of practice around an improvement collaborative, which is working really well, but it's in one city, and this is bringing together people from different communities within one city. Here, we want to bring together people from different cities in different countries to learn together across a number of different organizational barriers. The objectives are pretty straightforward. The intention is that there should be partnerships between the European cities that have met and those that are aspiring to meet the 95, 95, 95 goals. And the intention is that the learning should be focusing on those areas that are really key for success for all the cities to take their objectives forward. And the intention will be this community of learning among fast-track cities, and crucially, going back to the importance of policy in all this, thinking about common policy priorities and what they look like, what we can share, what we might be able to learn from each other, and possibly even do better together. So which are the cities that are the champions? They're on this list here. The ones with an S beside them have agreed to be part of the steering group, and that's Amsterdam, London, and Kyiv. And we are very sad that Kyiv isn't here. Indeed, the very first meeting we had of our steering group online was before the war, and I remember we were on Zoom and asking our colleagues in Kyiv how things were going, and optimistic and hoping it was going to be okay, and it's testament that they're unable to be with us today, but they are here with us in spirit. The list here includes cities that have reached these numerical targets, people who are aspiring to reach the numerical targets, but everybody on this list has got a shared ambition, and everybody on this list has expressed their commitment to doing this, even if everybody's at a different stage of their journey on the way through. So the intention is that we will run this over it's about a year and a half's project, and thank you to ViiV Healthcare for their financial support to make this happen. And the kickoff was in December 2021. Now I've tried to do some color coding here. If it's in gray, it's something to do about the admin and the support for the process. If it's in a kind of sludgy brown, it's about what the steering committee's got up to. If it's in green, it's about how we designed the workshops. And if it's in red, it's about delivery. But you can see that we started in 2021, end of last year, with a Zoom meeting, agreeing how we might get it, and some terms of reference were set up early in January. And with the establishment of the steering committee, each city on the steering committee contributes 3 members to the steering committee. And our first meeting was really interesting because the first thing we had to work out was what are people looking for in this? It's no good us saying, oh, wouldn't it be good to learn about this, if in fact everybody really wants to learn about that. So the first thing that happened was we designed, or at least we suggest the steering committee asked that a needs assessment survey be designed and sent out, and that was done. And I've got some results for that for you to see. And once we'd got the data from that, we had a report from the needs assessment which came back to the next steering committee meeting to try and think, in the light of what we'd learned, what we should be thinking about for speakers and how that might work. We also asked all the cities if they'd be prepared to be speakers and take part in the learning process, and everybody said yes. We then started to map the workshops, the speakers, the topics, and we are today at a really exciting moment because the first workshop is tomorrow. So this is very timely, and we're really excited, and it's going to go live. It's going to go hybrid. Is that a thing? It's going hybrid tomorrow here at the conference with our first session. There will be 5, and I'll explain to you. We had a bit of a, trying to find out from everybody together timing, how to do it. Would people prefer to do an hour every now and again, or a block of a week at a time, or how would it work? And we got a consensus view on how it might work, which I'll show you in a minute. But there's going to be 5 workshops altogether, and crucially, a post-workshop evaluation meeting in 2023 to see how it's all going. So that's where we've got to so far. So the needs assessment was really interesting. We asked everybody what it was they wanted to learn. And strengthening networks and collaboration was really top of the list. And that was fascinating because we have this glib approach. Oh, we'll just do some collaboration. We'll just do some partnership. It's work. It's complicated. It doesn't just happen. And so it was really interesting that cities were saying how we want to learn more about how that process works. There was a real interest in best practice, what people are doing, what's working, prevention and diagnosis next, PrEP, inclusive sexual health, people saying, well, how do we do a bigger piece than just HIV, maybe thinking wider and being more inclusive, stigma and discrimination, a bit lower down the list. And I was quite surprised people didn't want to know more about data, because certainly I was anxious that we maybe need more and better data, but it didn't come out as a learning thing that people wanted to learn a great deal about. We asked people when, and you have to remember we asked them in February when October seems like a long way off and everybody thinks their diaries is going to be empty. But they all said yes, yes, autumn. So here we are. The months September, October, November, so to be pitching our first one at a time when everybody said they really wanted it, no excuses for not being there. Because we did ask. And then we asked people what their particular challenges were, not what they wanted to learn, but what were they facing? And isn't it interesting? Political engagement was absolutely there. Now that, of course, is such a broad topic, national political, local political, city political, political with a small p, but it's clearly right in there for people's challenges to get things to move and how important it is if we are to make progress that we want to make. Working collaboratives, and of course money. Money, everybody is challenged with money, but it's interesting that it came in below policy. And I thought that was quite an interesting finding from this group of cities. But actually the city level data comes back. Interesting, they don't particularly want to learn about data, but they've got it as a challenge. So maybe it's, it's on the too difficult pile, I'm not quite sure, but that's where that is. And we asked everybody if they would use their own experience, their own stories as the basis of the learning collaborative. Would you be prepared to put your own challenges, your own story, warts and all its difficulties on the table as a preliminary exercise? And 70% said, yes, of course they would. So we hope we can embed the learning in the reality of cities' lives. So the topics are, as we've shown here, we've decided on the 5 topics plus the evaluation workshop. And the first one, which goes tomorrow, is about strengthening network working and collaboration. And then you can see the others, all of which fit, I hope, as you can see the overlap between the challenges and what cities asked us to include in the programme. So how are we going to run these workshops? Well, tomorrow is day 0, and we'll find out if this works. But the intention is we start with something theoretical. We start thinking about then examples of best practice, but always with input from the network, always with inputs from the real world, what's happening. We hope that in the identification of needs for each city, there will become opportunities for twinning with other cities that have got similar needs, or potentially with cities who've had that as a need and might have found a workaround around it. So there are potentials both ways around there. And throughout, this is participatory, dynamic, in real time. And I think one of the things we have to do from this is acknowledge what works, what doesn't. We'll try it. If this isn't the right approach, we modify it, and we are iterative about how it goes. Whatever comes from the twinning, we hope we'll have some advocacy. It'll feed into advocacy, and again, more inputs from the network, thinking about policy, and then thinking what is the next step. As we leave each workshop, what do we take from it to do in the next stage? So going from theory to practice with inputs in between as we go through. So how do we know if it's worked? What are our metrics? Well, this is what we've put in the terms of reference, and this is what we plan to evaluate against. Of course, the top one, evidence of progress across the cascade of care, ambitious to think we'll have anything to show at that level for some time. That is our long-term big aim. But to be brutally frank, to say that we will see that immediately is going to be taking time. And we would like to see at least 5 of the 20 cities feeling that that progress is there and having some evidence. If we can, we'd like to try and see 6 partnerships signed up to, other ways of twinning relationships actually documented, and then not just signing off, saying, yeah, great idea, love it, but then seeing it happen and actually having evidence that people are meeting, talking, communicating, regular touch points amongst all the participating cities. And actually this goes back to one of the things that we learned in London, was that although there were particular groups in our London Improvement Collaborative, the whole group was in itself a really important learning environment as well. So although the partners will learn, the group should also be learning at the same time. Whatever we're learning in our cohort of champions, it needs to go out, and it needs to go out to all the participating cities, and we will, at the end, have a report which we hope will have some recommendations, not just for interventions, but something about how learning happens. This is about learning as well as learning about the actual facts. So, to summarize, we've got a challenge. What is the Champions Challenge? Well, it's the discrepancies across Europe. I have a sense that in today's world, those discrepancies are going to get bigger and wider, and we're going to have to do more to close our gaps and to not leave everyone behind. We have different healthcare systems, and so something that works in one healthcare system might not work in another. Governance structures differ. We've got an array of things that are going to be different, and each twin is going to be bumping into really some quite important structural difference. But again, we may learn about each other's structural differences, which may in turn give us greater understanding. And also the same difference and heterogeneous healthcare delivery mechanisms in each city is also going to be important. What happens legally? Well, there's all sorts of constraints around what happens in practice, but also the legal constraints for people living with HIV, for communities, for migration, for citizenship, huge issues which are going to also bump into some of these twinning relationships, but they're also going to be central to those twinning relationships and hopefully be learning points. And as I've talked about, the different epidemics and trends, and hopefully finding a way that no city is working without a partner somewhere across Europe. But wow, what about the potential? We can talk about challenge as much as we like. But if this works, we've got the potential that this learning collaborative, ought to be able to improve outcomes for people living with and at risk of HIV. And I know it's we're at Fast Track Cities and we're target driven, but it's people. Underneath every single number are people, and making sure that people are living long and living well, and for people at risk of HIV have the prevention that they need. That's what we hope that this Champions project will take us at least towards. And of course, making progress towards those numbers, because those are the numbers that take us towards the end of this global epidemic. I think these sorts of relationships will provide resilience. We're in difficult times. There's no question that we're going to need to support each other in whatever's coming towards us. And the more we know of each other, the more we learn of each other, the better we will be able to work together. And I think the network will be stronger for doing this. Of course, we will share best practice, and we will, I hope, implement more of what works. But crucially, and I think this is another thing that I would reflect on what we've done in London, what doesn't work? And that's really important to know what doesn't work. And a negative outcome is a really important outcome. So how do we also avoid either reinventing the wheel or making mistakes of the past that other people have learned from? And I had actually a discussion with Gonzalo, a more cohesive Europe. Well, if all our cities are beginning to work more closely together, we understand each other, even if it's through the lens of HIV, we have got collaboration and partnerships in front of us. So this is the timetable for what's going to happen. You can see 2-hour blocks in these workshops, and those are the dates and times. Now, each KOL, Key Opinion Leader for APAC, in each city has been sent these dates. They have been asked to nominate 3 people. If you don't know about this and you're one of those cities on the list, find your KOL and go and tell them or ask them. If you're one of the KOLs and you haven't identified your 3 people yet, please do. This is an amazing opportunity. 20 cities, 3 people, 60 people in this learning collaborative. So it's now just time to say thank you very much to all the cities who've agreed to take part. It's going to be an amazing project, I think. It's not going to be necessarily easy, but goodness, it's got potential, and we're going to do, I think, a great job with this. The steering group, thank you for all the work that you've done. The Fast Track Cities Institute staff, Fast Track Cities London for support, and Gonzalo and Lucia, who have been consistently sorting out the steering group, the meetings, the Zooms, and Vive for funding us. Thank you very much.
Thank you so much, Professor Jane Anderson, for giving us such a wonderful insight on the complexity of Europe and also the richness of this continent, and also in terms of fast-track cities. Also, to not be ashamed of the negative outcomes. I believe that's one of the key messages that we all need to take. We need to share more what doesn't work so we can actually learn from it. And there is always this shame factor to it that I don't want to publish, I don't want other people to know about what hasn't run so well in what I'm doing. And also, to look more into the process, and having spoken with several of the fast-track cities across Europe, what we find is that we look too much into the outcomes and we only report on the outcomes. But really the piece of work is in the process. So how do I get things done? How do I get legal barriers to be flattened down? How can I address key populations? Although I don't like that term that much now these days. But so this is really the piece of work that we are trying to put together. And before I give it back to the audience, just wanted to tap in on Amsterdam, and having won yesterday, well, a Circle of Excellence award. I would ask you what you think is crucial within the Fast Track Cities initiative in Amsterdam to that led up to those numbers and figures and to the outcomes that you are having.
Yeah. Is it working? Yes.
Is it?
Otherwise, you speak up.
Yes.
Okay, I can speak. Okay, I think what's very important is political commitment, also on the city level from the beginning onwards, and that's difficult sometimes, and sometimes it's working hard, even in Amsterdam. So that's very important, and also I think we had the H team who was doing innovative on new innovations. That has been very important, and I think it's also important when you look at the cohort of champions to align with hepatitis programs and STI programs.
But maybe some people don't know about the H team, so if you could just zoom a little bit in onto that.
The H team is a collaboration between all stakeholders in Amsterdam, from community until clinical research. We sit together and look to the graphs and are looking forward, where can we improve, where we face difficulties, what can we do, which people are not involved, and then we start thinking about what we could do. We try out, and if it's working, we implement it. And try to implement it not only in the city, but also nationwide. Maybe Elske can give an example on that.
Yeah, it's basically a platform for innovation, and one very successful program was to increase awareness about acute HIV, but also implement a very rapid testing trajectory and linkage to care starting treatment within 24 hours, which led to an increase in the acute or early HIV diagnosis.
Yeah, and for example, now we are starting a community-led clinic for trans people.
Yes, that's indeed something I'd like to say about, because what's so nice about that is that we do it together with the community, the trans community. And well, Amsterdam had an early and quite effective response to the HIV epidemic, but also we are learning from other cities, and that's what I like so much about the twinning. This is what we learned, for example, from San Francisco, where they have really nice trans-led clinics, where they don't just offer sexual health services, but also psychosocial support and hormonal services. And that's now what we're offering in Amsterdam, together with community organization Trans United Europe. It's really a co-led clinic. And this afternoon in the Amsterdam case study presentation, I will tell a bit more about it.
And what is good in having both these cities here in this panel is that we go from a beverage model, right into another more private sector model without compromising the outcomes. And I believe that's the beauty of it. So we can work within this richness of healthcare systems without compromising our deliverables, and also how sensitive we are towards communities in delivering those care models. But now I don't want to take any more time. I would like to give back to the audience. So maybe someone from the tech team can help us with the microphones.
Otherwise, I will walk around.
Oh, thank you so much. This is learning and working collaborative.
Hi, I'm Rob Cooks and I work for the LGBT Foundation. We're based in Manchester. I'm also co-chair of Manchester Fast Track Cities. Really great presentation, Jane. I thought it was fantastic. I suppose my question is about how do some of the cities that are not part of that 20 kind of get involved, and because when I think of a city like Manchester, it's got a lot of things that it can bring to the table. It's also got a lot of learning to do, and I think that, yeah, so that's my question about, you know, how can we get involved in this, really?
We would love to have them involved.
Absolutely, and I think the question I would pose back actually to Fast Track Cities is what the number limitations are. And I think there was something about the funding envelope and the numbers of people we could accommodate, but whether that is still flexible and whether we can open more widely, I would defer back to the steering committee. I see absolutely no reason other than capacity for anybody to be part of this.
So it's really about that. So we have a limited number of 100 seats in our online meetings. That's about it. But otherwise, we welcome every fast-track city that wants to make part of it. The cities that are listed are simply in terms of, well, when we have to put up a proposal, we have to identify the cities that are working on this, and that there is a financial envelope to it, of course. But again, we are completely open to have Manchester or any other city that wants to join the Cohort of Champions project. So talk to me later today, and happy to have you on board. Maria, you're doing a great job. Thank you so much.
Hi, Jane. Great presentation. You're an amazing speaker. What do you plan to do with the already existing network of cohorts in Europe? For example, the Cascade Initiative. Is there any plans to get involved with them? We have the data, we have the collaborations there as well, and bring them on or incorporate them in this initiative.
So I think this is a really interesting point because there are initiatives and collaborations going on. This is, I think, something that's new and different, but it may well be when those cities come together. Some of these existing initiatives actually come out and become part of the process, and maybe part of the learning as well. So they're certainly not excluded, but I think for the moment the intention is to find cities as entities, if you like, who want to work together at that city level. And it goes back, I think, to something that you were saying about Amsterdam, is that political engagement and how we get the leverage within our cities. Now, if within that, there is an existing collaboration or there's existing data that will actually lubricate that, facilitate that, hooray. Yeah, let's go for it.
We'll go to the next question.
No, I can't. But maybe somebody with greater technical skills can.
Perdón.
Thank you, Ma'am Jane. I came when you were presenting, I missed the other presentations. So on the question of cities as entities, so an example from Africa, would cities in Africa, form an entity, and now these entities learn from the other entities, like the European model you just showed?
No reason why not.
Afterwards?
Yeah. Oh, you've done it. Well done. Thank you.
You're welcome.
My understanding is that this is a start. It's, we've got 20 European cities who are up for it. We've got some funding to do it. I think that if that report that comes out at the end of January shows that we've got something that really works, we should absolutely try and extend it. And I think then what would be fantastic would be if we had a cohort of champions in Africa as well as a cohort of champions in Europe. Then what? Particularly when we think about migration and diasporas and all those complexities, there would be an amazing amount of learning that could flow from that. So I think we've got, I see this as the beginning. We're starting in Europe, but the world is out there with so much to learn and so much to do. So I would be very enthusiastic. But I think we have to show proof of concept.
Definitely. And also going back to this conference themes about migration. So on our end, from the Europe side, we have a lot to learn from the African and also from America, from Latin American countries, because they are doing such a great job in terms of outreach programs, community-led programs. And in Europe, we tend to be too hospital-centric, which isn't always the best case when we look, for example, into stigma, so structural stigma. If I have to go to a hospital, in the back of my head, of course, I have a severe disease that needs specialized care. So that can also contribute to some extent to some stigma on the HIV front as well. But definitely something that after maturing the network of fast-track cities in Europe, we would like to expand it to other continents as well. Thank you. Any other questions? Then I would say we got a little bit over time. You still have 5 minutes for your coffee smoke, whatever. We look forward to having you tomorrow from 9 to 11 a.m. It's going to be in one of our session rooms here, but we're also going to be live for those who cannot attend in person. Thank you so much for having me.
Thank you.